Okay, so now that we're live, we want to introduce all our three speakers for the session, back to back. So our first speaker is Prof. Aristoteles. Yeah. Yes. He is from Athens, if I'm not wrong, Greece. Yes. So he holds a diploma from the School of Electrical and Computer Engineering, and he's in the engineering, or he's an engineer in industrial consulting in Germany, and he has interestingly authored and co-authored more than 250 journals and international papers, and 21 PhD theses and 18 diplomas. If I do that, then I retire. And he's going to be speaking to us about data to information mining. And then Dr. Rahava, my brain, will introduce the next speakers, and then we'll sit down and the speakers will just come back to back.
All right, thank you, my esteemed colleague. Good morning, everyone. So seems like I'll just do a short introduction for the next two speakers, and then just before the second speaker ascends the podium, then I can quickly introduce her. The next speaker will be Dr. Kim Blenman from Yale Cancer University, and then she'll be followed by Dr. Elise Leded. Over to you.
So, good morning. Welcome to everyone. And the third day of this so interesting meeting. Actually take the opportunity to express my thanks to the organizer for being part of this initiative. It's so inspiring. It really gave me the opportunity to meet so interesting peers from all over the globe. And I really think that the PACR initiative has huge potential for, in the near future for the research in cancer. So the work that I'm going to present today has been mostly committed to the spin-off company, INEOS, that I have found some years ago. And in INEOS is a digital biotech company, and we are really keen and embrace the concept of personalization, and we strive to make use of AI in the ways that they really facilitate the integration of precision medicine applications in the clinical setting. So having said that, I would say that precision medicine represents a huge paradigm shift, which comes to change the outdated one-size-fits-all approach to therapy and replace it with one that aims to exploit the genetic background of patients in the broader sense in order to align patients with the optimal therapeutic response. However, precision medicine in reality is hindered by the biological interpretation bottleneck. And everybody who is in the omics analysis business knows very well that now we are literally deluged by exponentially growing data all the time, which really need to be analyzed meaningfully on the fly. And if the failure to do that practically prevents organic integration of precision medicine, especially in the clinical routine. When we speak about interpretation, it should be, we should clear out that we speak about the extraction of actionable information from big genomic data. And when we say actionable, we mean information that can be nicely used in order to provide insights for the clinical setting. So, there is a long list of caveats in biological interpretation. To name a few, the first concerns the lack of consensus methodology. A very, very important thing is that the methodologies that are used for interpretation are mostly statistically dominated and not biology-driven. The statistical assumptions that are used in most of the cases can be fallacious, so they do not represent the actual complexity that we encounter in the actual biological problem. Moreover, the typical data mining and machine learning techniques, and I would extend that to incorporate all mathematical operations that are being performed in the context of signal processing, are overly sensitive to random correlations. And this can be really important because many people with, let's say, limited knowledge in the field may be tempted to adopt the misleading connotation that statistical correlation means association, which is not the case. And I will discuss that with you in the next few minutes. Other challenges stem from the huge data complexity, which is coming from different sources, and of course the huge model complexity, that is the underlying complexity of the logic, the complex logic of the biological mechanism that we study. So, AI has been hailed as the solution to all our problems, but the actual the reality is that its meaningful introduction in real-world problems is far from direct, and this is because what generic machine learning methodologies perform is actually correlation-based modeling, and they do that in order to infer interesting geometric patterns. But when we perform correlations, we always need to bear in mind what is the basis of our correlation, so what we use in order to correlate with. And this image, which is the result of an object recognition problem in the Deep Dream Google algorithm, shows the limitations if that was to be used, for modeling purposes. So the camera is perceived as a sort of an exotic animal, just because the basis of this correlation are the many images in the internet, which have been probably posted there by the owner of these animals, and which literally create a huge bias in terms of images. So the most frequent imaging patterns that you will encounter in the internet concern animals, and that's why the camera tend to be correlated and perceived as an animal. So intelligent modeling at the concept level should ideally embrace also ontological vocabularies, so that is control vocabularies that describe qualitatively the different critical components that describe any subject, any mechanism, any problem that we study. And this is essentially what we are doing with BioInfoMiner. We try to develop a framework for computational biological reasoning, which makes use of ontological vocabularies in order to model biological concepts. It aims to identify critical independent biological mechanisms, that is, distinct subcircuits, and it uses these ontological vocabularies and couples them with graph theoretic algorithms and appropriate semantic similarity measures in order to highlight molecular factors, genes or variants, which have a central role in these distinct biological components. Moreover, it provides prioritization of genes and variants, and in this way, biological complexity can be distilled into compact signatures, which are highly informative rich. And I will discuss in the next few minutes with you how we do that by providing a short methodological background. So some of the main tenets behind the design of BioInfoMiner is that signal distributions in any biological, let's say in any omic experiment, are stochastically structured. That means that if we sort the signal distribution according to the order of p-values, different p-value levels allude to distinct circuits enriched. This is a key concept. And in this sense, ontological term defined, which can be highlighted through high-performing enrichment statistics, define gene cliques that have a concerted function. So we could understand them as cogwheels in a very complex machine that perform a distinct function. And the regulatory hubs, that is the linker genes within these cogwheels, act as pinions, which enable the systemic spillover. So we can have, moreover, after we have derived this signature of core regulatory genes, we can go and search in the proximal vicinity of these genes by exploiting interaction repositories in order to find potentially interesting interactions which have with their own, in series, a huge impact to this systemic spillover. This is the algorithmic workflow, and as you can see, the algorithm may accommodate different types of biological data, be it expression or structural variations or methylations. And essentially, the first stage is to map these signals to genes. Then we perform insightful enrichment analysis, and I explain in a minute what it is. The terms that are thus derived are mapped on the ontological tree, which has to then be corrected for annotation inconsistencies, lack of annotation, or more importantly, bias of annotation. And then we derive the sub-ontology, the correct sub-ontology, and on that we perform the semantic topological analysis and we derive the semantic signatures. The biologically non-trivial enrichment is a key step, as classical enrichment testing yields myriads of highly statistically significant, yet informationally insignificant terms. So these are the classical enrichment scores of 1 out of 1, 1 out of 2, who everybody who has analyzed omics data is coming across with. And these, from the pathway perspective, are considered entirely trivial. There are actually artifacts of the build-up of the ontological tree itself. And essentially, we would like to filter them out. But you cannot do that, in a supervised way, because the ontological trees have different branches. So you cannot select different branches. And what we have done is we have developed resampling-based techniques that automate this procedure. And essentially, we can take into account not just the significance of the statistical score, but also the rarity of this enrichment. And in this way, we can very, very safely and more importantly, automatically come up with a highly informative, let's say, trimmed version of the ontological tree that describes the complexity in our problem. And having derived that, we project these terms on the ontological tree, and then we can perform this so-called semantic processing using different semantic similarity operators. And in this way, we can regroup all these terms to broader, let's say, processes, the so-called systemic processes, which have the concerted function. And these represent the broader genetic circuits that is perturbed in our problem. Having done that, we can then exploit the other part of the ontological graph, because we should always bear in mind that ontological graphs are bipartite graphs. So on one hand, we describe their function, and on the other hand, we have the genes related with them. And now we can exploit the gene part of the ontological graph, and we can perform connectivity analysis, and we can thus find which genes have higher connectivity with these systemic processes. And in this way, we can derive automatically a compact set of co-regulatory genes. So the signatures that we have derived have a dual representation. They have a systemic process part and a gene part. And the systemic processes represent fundamental, I would say orthogonal, largely orthogonal biological functions. So in terms of gene composition, they have minimal gene overlap with each other. And the prioritized genes, which are standing in between of all these systemic processes, possess strong association with the phenotypes, the molecular phenotypes, which is the systemic processes. And that means that small changes in these genes may have large impact, just simply because they regulate many different processes. And semantic structures, on the other hand, represent structures that provide neat mechanistic interpretation, highlighting whole gene circuits rather than single genes. And then comparison between signatures can be more robust, as functions tend to be more conserved than single genes. So they are noise resilient. Even if single genes are artifacts, this does not harm the functional interpretation. And as we have the topology and the topological map through the projection into the ontological tree, they can very, very easily compare to each other in terms of their functional relevance. Having said that, now I will present a couple of applications. The first is what we term signature-aided in silico clinical trials, where we use this methodology in order to exploit the treasure trove of TCGA. And actually, I would really welcome the creation of an African genome cancer atlas, we would be really happy to participate in that and analyze and provide analytic scenarios for such a repository. Essentially, what we need to do, we need to transform the genomic component of each sample residing in this data set to a semantic signature, which can then be readily compared with each other. And in order to do that, our solution performs cross-platform harmonization, and in this way we can even integrate different technologies, so we can co-analyze RNA-seq and microarray data. We get from each sample a semantic signature that describes the specific sample, and then by performing functional clustering, we can perform a comparative phylogenetic analysis that characterizes these samples. And in this sense, based on the results of this clustering, we can then perform survival analysis to see if there are differences, significant differences in these clusters. And as you can see, we showcase that to the urothelial bladder cancer cohort of TCGA. And within 10 minutes, we were able to analyze the whole data set, extract 400 signatures for each sample, perform this clustering analysis, which highlights two neatly described different clusters. And then the survival analysis that was done highlighted the strong statistical significance that exists between these two clusters. More importantly, these clusters have a very neat mechanistic interpretation. I will show that for the sake of the time to the second application, what we rescued from the mechanistic information. And you can see that this cluster especially is very, very similar. So the samples are very, very similar to each other. The others seem to be a bit more diverse, but important is to say that when we compare that with other methodologies that had a signature of the same size, and we use any type of combination, try to select genes from the significant list, we fail to have this type of statistical significance. So the second type of application is with respect to precision oncology, and here we emphasize on what we can get from a single sample and how we can readily integrate the different types of information that describe a certain sample in order to get a personalized signature, which can then be linked, and we have implemented that readily with different pharmacogenomic repositories in order to have a good idea of which drugs could target specific genes of the signature. And we showcase that in samples from the head and neck squamous cell carcinoma TCGA collection. We picked randomly 10 cancer patient samples, and we contrasted them with the expression of 44 healthy controls. Our statistical selection methodology was such to exclude any false positives, so we picked only genes in each sample whose variation was above the variation that we see across all the healthy, and then we sorted them according to the magnitude of this variation, and we picked the top 5%. And in this way, for each sample, we derived a semantic signature, and then we compared them. So as you can see, we use different vocabularies, and actually this is something that can be really useful because it can provide other players. But you can see that the clusters are quite neat, so we don't have large differences. So the clusters describe genes, samples that have a similar mechanism of action. And using the gene ontology, we can see that this part of the cluster these samples are mostly using as method of activation the unfolded protein response. So they have a strong overexpression of heat shock proteins. That means that they could be probably targeted by heat shock protein inhibitors. If we get into account the other cluster, we will see that the samples in this cluster overactivate the proteasome. And that means that probably they could be proteasomal inhibitors could be good options for these patients. Doing the same with the human phenotype ontology, we will see that now we have 3 clusters, but we see very, very strong upregulation of collagenases and laminins. And you should have in mind that laminins are encountered in all 3 clusters with very, very serious overexpression. And that means that actually laminins could represent a very appealing target for the management of head and neck cancer patients. And indeed, according to the, there are drugs, there are human fusion recombinant proteins which target laminins that are already in clinical trials for other types of cancers, or there are recombinant proteases that are used for for the treatment of other, let's say, diseases like vitreomacular adhesion, which have a specific activity against laminins, and I would say fibronectin. And I mentioned fibronectin because you will see it in the cluster 2 of this analysis according to the mammalian phenotype ontology. Here, cluster 1 is providing extra insight as it shows that there is a specific calcium-gated channel that is severely underexpressed for all these samples, and that disrupts calcium homeostasis in the cytosolic side, and that probably could be an interesting target. Whereas in the case of cluster 2, we have very, very, very strong upregulation of fibronectin, which means that, again, fibronectin could be an appealing target for this patient. So, wrapping up, I could say that bio-inspired AI may accelerate drug development in a dual setting, in the preclinical by identifying novel drug candidates, generating novel druggable biomarkers, or by performing drug repurposing studies, exploiting existing pharmacogenomic data about drugs. And in the clinical setting, it can facilitate the organization of next-generation sequencing-driven clinical trials, where we can identify the patients who could benefit from treatments, and we can thus suggest patient enrichment strategies to increase success rates and through adaptive clinical trial designs. In summarizing, I hope I was able to convince you that semantic network analysis represents a promising, powerful avenue for automated, insightful interpretation of omic data. It provides a generic, noise-resilient framework for systemic interpretation across all levels of the complexity iceberg. It can integrate different and sizable omics, data type omics. So it is the appropriate vehicle for deep and broad integration. It's relieved from the constraints of the size of the distribution, and that makes it an ideal way of designing prospective studies rather than the retrospective. It represents a bio-inspired feature selection process, and in this way, it's suitable also to further train and enhance the performance of other AI learning frameworks, like, machine learning or deep learning operators. It supports numerous biological endpoints, so expressions or variations of different sorts. And last but not least, it is appropriate for unceasing computing in order to mine information. So with that, I would like to thank you. And I would also like to thank all members of my group and my collaborators, of course. Primarily, I would like to mention Eleftherios Pilalis, who has been a very, very good companion in this journey throughout these years, and Christina Andrinopoulou and Bianca Passat, who have played an important role for providing the functionality that the platform has currently. Thank you, and of course, I will be happy to answer to your questions.
Thank you very much. Yeah. So what we will do is we'll get the next speaker on, and after our 3 speakers for this sessions have ascended and spoken, Then we can have, a Q&A after that. Our next speaker was introduced earlier by Dr. Rahava, but she can just recap a little bit for us.
All right. Our next current speaker is Dr. Kim Blenman. She's an assistant professor in the Yale School of Medicine, section of medical oncology. She's also an assistant professor in the same university in the School of Engineering and Applied Sciences. Well, Dr. Kim has been to industry and now she has re-entered academia. Her current research interests include clinical research, therapeutic development, and health disparities, with a particular focus on cancer and autoimmunity. Over to you, Dr. Kim.
Okay, fantastic. Thank you so much. Good morning. Good morning. So happy Wednesday. And first and foremost, I'd like to thank the organizers for inviting me to give this talk this morning. The COVID-19 pandemic has reinforced that we, as a global society, are only as strong as our weakest systems, and we must consider inclusivity and equity in all facets of our systems, especially those that deal with healthcare. As we are building tools to improve health outcomes, we must consider the viability of using those tools in low-resource environments. And so I'd like to share with you today the development of hardware, software, and statistical methods to enable computational science in low-resource environments worldwide. So computational pathology in the context of histology has exploded over the past few years with the advent of quantitative imaging microscopes and more sophisticated machine learning, deep learning software, clinical use of artificial intelligence and machine learning software requires performance assessments, which can be accomplished through reader studies. However, there is no blueprint for this process. So this morning, I will discuss our efforts to develop a blueprint for reader studies that include design of hardware, software, and statistical methods that can be used in all environments, especially low resource. There we go. So I will talk about, so as a brief outline, I will talk about the model that we are using to develop the blueprint. I will give an example of a digital pathology AI tool that was used to predict pathologic complete response, or PCR, in a National Institute of Health, National Cancer Institute neoadjuvant chemotherapy trial. I will then give a brief explanation of reader studies, and then I will wrap up with talking about an ongoing project to create a validation data set for software tool developers to test their algorithms performance for software tools that they will submit to the FDA for approval for clinical use. So the model that we are using is breast cancer. And for those of you in the audience with general backgrounds, so globally, there are over 2 million new cases worldwide in 2020 of breast cancer cases. The major subtypes are hormone positive, HER2 overexpressors, and triple negative, based primarily on positivity of estrogen, progesterone, and human epidermal growth factor receptor. A rare subtype is inflammatory breast cancer. The rates and lifetime risk are higher in developed countries than in developing countries, as you see in the panel on the right. Some of these breast cancer microenvironments contain a significant amount of tumor-infiltrating immune cells called TILs. This is an image from one of our patients. And here you can see quite nicely the islands of large breast cancer cells and the streams of immune cells with condensed dark nuclei in the stroma. As we look at the pathologic complete response, or the PCR rates, to neoadjuvant chemotherapy by baseline TILs counts, we found that high levels of immune infiltration in breast cancer are associated with better prognosis, regardless of the therapy that's used, and with higher chemotherapy sensitivity. So TILs counts, or tumor infiltrating lymphocyte count, has also been found to be a prognostic for survival in breast cancer. As a result, there is an interest in developing methods and tools that can accurately quantify TILs. So I share an example of a digital pathology AI tool that my research team developed. And so the National Institute of Health, National Cancer Institute Southwest Oncology Group consortium had a trial that was labeled as an S0800 study, which was a phase 2 trial of bevacizumab, which is an anti-VEGF inhibitor, versus standard of care chemotherapy in patients with HER2 negative, locally advanced breast cancer or inflammatory breast cancer. So pathologic complete response for PCR in the trial was significantly higher in the bevacizumab arm overall, which was reflected in significance in the triple negative breast cancer and in trends in the inflammatory breast cancer and the hormone positive subtypes. So these results inspired us to look for a simple biomarker or marker of response to therapies such as bevacizumab. So as I mentioned, the TILs within the tumor immune microenvironment have been proven to be prognostic and chemotherapy response predictive for a variety of cancers. TILs are predictive of higher PCR rates and are associated with better survival in breast cancers overall. The simplest metric of TILs is the manual stromal TIL score, defined as the percentage of tumor stromal area occupied by mononuclear immune cells in hematoxin and eosin stained slides or H&E slides. Therefore, we decided to examine the association of manual S-TIL score with PCR, event-free survival, and overall survival in the SWOG S0800 study. Classifying baseline TILs into approximate quartiles or as a continuous variable showed a weak association with PCR. There was no significant association with event-free survival, overall survival, and baseline S-TIL score either as a continuous variable or as quartiles. And for us, this really begged the question as of how good are we at manual S-TIL scoring? So when we compare the variance in manual S-TIL scores between 29 pathologists who are not experts in manual TIL scoring, we see that there's a significant variance. When we compare a subset of 72 selected regions of interest between 7 non-experts and 8 experts in manual S-TIL scoring, we found that the variability of the crowd was at least 3.5 times higher than that of the experts. However, even the expert has appreciable variability in manual S-TIL scoring among them. So what have we learned? So we've learned that there is an association between manual S-TIL score and PCR. We've learned that we can leverage simple H&E slides and manual S-TIL scores to predict PCR and survival in any environment, including low resource, because H&E slides are literally the first step in any of our diagnosis. So what are the gaps? So our studies and studies in the literature have revealed that manual S-TILs scoring is labor intensive. Scores between pathologists on the same slides have high variability. And then clinical adoption of S-TIL scoring is hindered by the amount of time required for scoring and the variability between the scores. So how can we help pathologists reduce the amount of time that is spent on S-TIL scoring and decrease the variability between pathologist score? One method is potentially through digital TIL scoring. So there are many hardware and corresponding software tools available for digital TIL scoring in the field that has now become digital pathology. So the question that we asked was, can we create an image analysis-based TILs measurement that predicts breast cancer PCR at least as good as manual S-TIL scoring? Our data set consisted of 113 pretreatment cases from the SWOG S0800 neoadjuvant chemotherapy trial. We used QPath software and an algorithm consisting of a convolutional neural network cell classifier, CNN11, to create EAS TILs % as a digital metric of TILs score defined as the sum of TILs area over the stromal area times 100%. The EAS TILs % is the closest that we've come so far in our hands to getting to a digital version of the manual S-TIL score. So this is demographics of the original the SWOG data set with 211 patients. This is the digital TILS subgroup with 113 patients with pretreatment samples only. There is no difference between the original and the subgroup. So here on our right is an example of H&E stain images with their corresponding image analysis-based cell classifications, highlighting individual tumor cells in red, TILs or tumor infiltrating lymphocytes in purple, fibroblasts in green, and other cells in yellow. So these are the digital TILs. These are the manual TILs. So overall, TILs are higher in patients that achieve PCR compared to with those with residual disease, with a more significant p-value with digital TILs compared to manual TILs. Only comparison of TILs in bevacizumab arm showed a significant difference between patients who achieved PCR and those who had residual disease, with a more significant p-value with digital TILs compared to manual TILs. The differences were not significant in the chemo alone arms. Assessment of PCR rates show that there are significantly higher PCR rates with bevacizumab in patients with high pretreatment digital TILs, yielding more significant p-values. Manual TILs and digital TILs are highly correlated. And receiver operating characteristic curves show that digital TIL scoring is potentially a better predictor of response than manual TIL scoring, which is shown in the left and comparable with the image on the right. So what have we learned? So we observed strong positive correlation between digital TILs and manual TILs. The area under the receiver operated characteristic curve was higher for the digital TILs than the actual manual TILs. And finally, image analysis-based TILs quantification is predictive of PCR and breast cancer and had a better response discrimination than the manual pathology-read manual TILs, stromal TILs. So with that in mind, I would like to mention that as a field, we have a lot of artificial intelligence and machine learning tools in the pipeline that are being created for digital pathology for use in clinical care. And because of this, we need, and it's critical that we need a process to verify and validate the performance of the assessments. And so this is where reader studies come in. So practical methods to optimize and validate software tools for pathology include reader studies. So reader studies are used to collect image annotations, which includes, physical markings on digital images and slides, includes diagnosis and measurements being included in the data set. Reader studies are used to evaluate and understand variability in quantitative assessments. They can be used to demonstrate how to create a reference standard for training and testing software algorithms. And they can be used as an educational tool to improve assessments. So in digital pathology, pathologists are presented with images and questions that include annotations of objects in the image. A great example is using the digital pathology and reader studies for a TILS density assessment in H&E stained slides from biopsy tissues. So this leads me to an ongoing project. And this ongoing project is a collaboration with the FDA to create a high quality validation data set, which includes images, slides, and clinically annotated slides and pathology annotations. That will be provided along with a statistical software package for data analysis to algorithm developers for validation of their performance of H&E TILS assessments when they submit their algorithms to the FDA for approval for use in clinical care. So this is designed to be used in any resource environment, including a low resource. We are currently recruiting pathologists worldwide to provide data sets and assist with annotations to ensure that we are representing the global community that we live in, to ensure equity in the products that are being produced for clinical care. So on the right here, I literally show the workflow of the study. And so the RETA study involves on the left, on the right. The RETA study involves setting up a data set of H&E slides and regions of interest for TILS assessment. There are literally 3 general tasks, which include first labeling the region of interest, and then indicating the TILS assessment eligibility for that region of interest, and then scoring or recording the percentage of TILS. So this is done on multiple platforms, including 2 digital platforms, the first being PathFinder and the second being CA Microscope, and 1 low complexity automated microscope platform, EDAP, that was created by the FDA. So these are blowups of the screenshots from the graphical user interfaces of the 3 platforms used in the data collection from the RETA studies. Again, in general, there's a question asked about whether there is a tumor and or stroma in the regions of interest shown. And if there is, what percentage of TILs are in the stroma. And so here is an example of an output where we show the S-TILs density on the x-axis and the frequency of those actual S-TILs on the y-axis. And that's literally to give you an idea of the general output and the distribution of cases that we're getting so far. So for our pilot study, which is currently ongoing, we have 64 H&E breast cancer slides with 640 regions of interest tested with those 2 digital platforms that I mentioned in the previous slide, and the FDA EDAP microscope platform. So again, I show the variance in manual S-TIL scores for this study, which I showed previously. And I wanted to just mention that the variance is actually due to heterogeneity of the regions of interest that are evaluated, and that we have created a continuing medical education course to teach how to do manual S-TIL scoring in order to reduce the variance. So in conclusion, we are creating a validation data set, or a reference standard, so to speak, to assess the performance of artificial intelligence and machine learning tools that are termed software as medical devices by the FDA as, or SAMD, that will be submitted to the FDA for approval for their clinical use. The validation data set can be used in low resource environments. We are recruiting pathologists worldwide, licensed or trainees, to provide data sets and annotations. So again, if you or anyone you know are interested, please contact me. And then we have also, and finally, created a CME course for manual S-TILs quantification to help to reduce the variability in the assessments that we've seen. And ending, I'd like to really acknowledge my research team, and to also acknowledge the several Yale groups that have been instrumental in this study. So mainly the biostatistics group, my medical oncology colleagues, our pathology colleagues, especially Dr. Yilai Bai, who's created the original algorithm. And then also the wonderful NCI team, the SWOG 0800 team that put together the study. And I'd also like to thank, most importantly, all the patients who participated in this clinical trial. So thank you.
Thank you so much, Dr. Kim. Would you please stay until the end of the session, which is exactly after the next speaker. So we'll be taking all questions and answers after then. Thank you.
Thank you.
So our next speaker is Dr. Elisa Ledet from Tulane Cancer Center. She obtained a PhD in genetics, and her graduate training primarily focused on prostate cancer, epidemiology, hereditary, as well as prostate cancer disparities. Her current and long-term goals include elucidating mechanisms that underlie prostate cancer heterogeneity. Over to you, Doug.
Good morning. I'm Elisa. Thank you so much for inviting me. Thank you, Professor Dalmini. This has been a great experience. So today I'm going to talk to you about the genetic landscape of prostate cancer, and this is a pretty generic title for this talk. It should be more specifically looking at some of the genetic, germline, and somatic variants in advanced prostate cancer, with a specific emphasis on prostate cancer disparity in the African American population. So a little bit about the genetics of prostate cancer. So this is a very heterogeneous disease that's full of heterogeneity. There have been candidate prostate cancer loci that have been identified. The first segregation analysis identifying hereditary loci in prostate cancer were actually done in 1949. So this is a quest that's been going on for quite some time, but unfortunately, the only alterations and variants that we've identified have been low to moderate and rare risk alleles associated with prostate cancer. So more than 60 loci specifically have been identified in relation to hereditary prostate cancer. These include like the DNA repair genes, which would be expected, mismatch repair, as well as one prostate-specific gene, which is relatively rare, but that's in HOXB13. So in advanced prostate cancer, Dr. Sartor also mentioned this study, but in 2016, Pritchard and Colin Pritchard and his group looked at germline variants in advanced prostate cancer patients. And what they found was about 12% of patients had pathogenic germline alterations in DNA repair genes. And this included 5% of men with localized prostate cancer. So this is much higher than what was previously expected. So following that study, what we wanted to look at was what were the overall frequency of germline pathogenic alterations in men with prostate cancer. So what we did was we teamed up with a clinical genetic testing company, and we looked at their entire database for patients tested between 2013 and 2018, which included about 3,600 prostate cancer patients. Unfortunately, these patients were only minimally clinically annotated. So aside from the diagnosis of prostate cancer, we didn't have a lot of clinical annotation. That being said, we did have pretty good family history annotation, and we had a lot of data as far as demographics. So without going into all the details of that large study, we did find that there were significant variations between the racial groups in the study. African Americans and Hispanic patients had lower rates of pathogenic or likely pathogenic variants. Specifically of interest, the DNA damage repair genes, there was a significant difference with African Americans having fewer pathogenic alterations in the DNA repair genes. In the non-BRCA genes in this panel, they also occurred at a lower frequency among African American men. This was very interesting to us, and unfortunately, since we didn't have the clinical annotation, we wanted to take it a step further. It's also interesting to note that in this study, when we looked at family history, if we tested these patients purely according to NCCN criteria at the time of the study, 39% of the patients who were tested would not have been tested if they adhered to the NCCN guidelines. So this study, along with others, helped push things forward to change the NCCN guidelines to be more encompassing for advanced prostate cancer patients. Interestingly, in this study, we also found that CHEK2 was less frequently altered in the African American patients compared to the Caucasian patients, but there were no other big distinctions we identified. So to take this one step further and to incorporate clinical annotation and more detailed family history, we did a collaborative study with 7 other sites in the United States, specifically looking at African American prostate cancer patients who had distant metastatic disease and who had germline panel testing. So overall, there was no significant difference in the likelihood of a pathogenic or likely pathogenic variant between African Americans and Caucasians in these cohorts. However, African Americans were more likely to have a variant of unknown significance, when compared to Caucasians. About 55% of the African American patients had a variant of unknown significance. This is likely due to the fact that African Americans are underrepresented in the databases which are used to identify and to quantify pathogenic and likely pathogenic variants. So this wasn't exactly a surprise to us, but it was important to show and to prove that this was a fact. So interestingly, we also found that African Americans were more likely to have a BRCA1 pathogenic alteration as compared to Caucasians. This finding has also been shown in Nigerian populations. Recently in September, there was a publication and they found the same increased frequency of BRCA1 in African Americans as well as the Nigerian population, prostate cancer population. We also identified VUSs that were significantly more frequent in African Americans in BRCA2, PALB2, and PITCH1. So excluding BRCA1 from the analysis was important to us because we wanted to see what was happening in the other genes, and that signal was so strong, we wanted to evaluate in the other DNA repair genes, are there other differences that we're missing? So, African American patients were less likely to have a pathogenic or likely pathogenic alteration in non-BRCA DNA repair genes. African Americans were, you can imagine this on lovely tables. So African American patients were less likely to have a pathogenic or likely pathogenic in any non-BRCA gene. So imagine the next slide is changing. Most interestingly from this study, we did look in depth at cancer family history. So interestingly, while Caucasians were more likely to have at least one first-degree relative with ovarian cancer, we didn't find that in the African American population. This is significant because the NCCN criteria is directly related and directly identifies ovarian, breast as specific indicators for testing. We did not find a significant difference. Ooh, exciting. We didn't find a significant difference in African Americans or Caucasians with relation to prostate cancer family history with at least one first-degree relative. In breast cancer, interestingly, there was no significant difference in the likelihood of a pathogenic alteration in African Americans with at least one family, with one first-degree relative with breast cancer. So what you can't see right now is we're going to change gears a little bit and talk about the somatic changes we see in MCRPC. In prostate cancer, unfortunately, we often don't have access to tissue beyond the primary tissue obtained at diagnosis. So in the metastatic setting, evaluating tumoral changes in real time is often fraught and not realistically feasible unless you look in the circulation. So in the following slides, which you can't see, we are looking at somatic changes in circulating tumor DNA in MCRPC patients. So previously somatic analyses have identified genetic distinctions between African Americans as compared to Caucasians in MCRPC patients. These prior studies were done in tissue through rapid autopsy, most often, and they identified a broad spectrum of mutations which are more frequently altered in African Americans. This included an increased frequency of FOXA1 and a decreased frequency of TP53 mutations in African Americans as compared to Caucasian patients. Also, in patients receiving androgen deprivation therapy, AR, TP53, SPOP, and BRCA2 were more frequently mutated in African Americans as compared to Caucasians. So that was in tissue. So what did we find in the circulating tumor DNA? So in the single institution study we did, which you can't see, we evaluated 250 MCRPC patients after treatment with abiraterone and enzalutamide. We selected this this treatment time point because these are the patients who are beginning, who are metastatic, who are at the beginning of their treatment course in the metastatic setting. So we wanted to have a clinically relevant and realistic cohort, which reflects where we are as far as prostate cancer treatment. So in this, we included 50 African-American patients as well as 200 Caucasian patients. We assessed ctDNA with the Guardant 360 assay. This is part of their clinical standard of care. These panels included 70 to 83 genes, and these assays were conducted between 2015 and 2022. Only pathogenic mutations with a variant allele fraction of at least 0.5 were considered. Pathogenic mutations included a wide variety of types of mutations, which were identified: missense, indel, amplification, frame shifts, nonsense. However, deletions are not identified. Oh, it's back. Deletions are not identified as of yet in this data. We also excluded synonymous mutations for this study. So what did we find? This is again is pretty expected. Our African American patients were younger at diagnosis and were ultimately younger at onset of CRPC, and this is something that we've seen across the board. Importantly to note is that both our African American and Caucasian cohorts had no significant difference in the life-extending treatments prior to ctDNA assessment. So clinically, these patients were reasonably well matched, especially with reference to treatments prior to their Guardant testing. So what did we identify? So the first important thing we found was that about 20% of patients, regardless of if they were African American or Caucasian, about 20% had no detectable ctDNA alterations. We know from our ongoing work and previous work that the likelihood of detection of ctDNA alteration goes down as patients progress. So this was expected as well. What was unexpected was we found that frame shift mutations were significantly more common in our African American populations. This is especially interesting because frame shift mutation proportion has been shown to correlate with anti-PD-L1 treatment efficacy. So this along with what the next finding is especially interesting as a potential opportunity for precision medicine in this population. So what we did find, which was especially interesting, was that the frequency of CDK12 and KIT was significantly different between the African Americans and the Caucasian patients. CDK12 most notably was increased in the African American population. We also saw this trend in the TCGA data, as well as another study that we conducted with data from the Tempus data set. In that Tempus data set, we specifically looked at 3,000 prostate cancer patients, 98% of which who were metastatic, and we also found that CDK12 was significantly increased in African Americans in that larger data set. So this was of particular interest to us, specifically because of the implications for precision medicine. CDK and MCRPC, CDK12 status in MCRPC is especially relevant because CDK12 alterations often are indicative of poor prognosis. These patients tend to have a higher Gleason score when they're diagnosed. They progress very quickly and unfortunately have a lower overall survival. Now this is important because of immune checkpoint inhibitors. In general, in metastatic prostate cancer, it has been shown to be poorly immunogenic. So generally, prostate cancer patients don't respond well to these ICIs. However, it's been proposed that CDK12 mutated prostate cancers may be more susceptible to ICIs, which is especially interesting. Additionally, In the pan-cancer analysis of solid tumors, tumor genomes with frameshift mutations and increased expressions of neoantigens have been shown to be correlated to T-cell activation and, again, ICI response. So applying these conclusions together from our study, and given the increase in the CDK12 and the frameshift mutations we've detected, it raises the possibility that MCRPC tumors in African Americans may have more immunogenicity, and that MCRPC tumors in Caucasians compared to Caucasian patients. However, there's no data comparing the effect of ICI among different ethnic groups in the MCRPC setting. Interestingly, we did do a very small clinical trial looking at avulimab in African American patients. It was a very small trial, and unfortunately, our African American patients progressed very quickly. But other than that, we haven't found any other studies or clinical trials specifically looking at ICIs in African Americans. So, in summary, germline is very important, and again has important implications for our precision medicine. In the MCRPC population, 12 to 17% of patients, regardless of family history, have pathogenic germline findings. African Americans were significantly more likely to have variants of unknown significance, and this is likely due to underrepresentation in the larger databases which are used to define these variants. Again, African Americans were more likely to have BRCA1 mutations, which also opens up opportunities for precision medicine. Family history and germline testing are critical and underutilized in these populations, and overall is a point which needs to be addressed in the future. As far as somatic changes, again, we looked at ctDNA. ctDNA is screening and an important tool for evaluating tumoral changes in real time in these patients. This can have direct influences on treatment decision making. Again, in the MCRPC post-abiraterone, post-enzalutamide setting, African Americans were more likely to have somatic changes in CDK12 and KIT, and frameshift mutations were more frequent in these populations. So these represent novel findings which may have important implications for treatment options and treatment decision-making in the future. So, as you can see, we have a lot of acknowledgements. We've worked with a lot of wonderful people, both internally and at Tulane, as well as across the U.S. And I hope this slide also speaks to our willingness to collaborate and willingness to work with a wide group of people so that we can address these issues with disparity, as well as the genetics of prostate cancer in the future. And of course, thanks to our patients, because without our patients, this wouldn't be possible. So all of this data reflects real people in a real clinic, and it's important that we remember where this comes from and who this is for. Thank you very much.
Thank you so much, Doc. So we'll be starting off with a QA session with Dr. Elise. She'll be followed by Prof over there. And then last will be Dr. Kim. So
Please come in. You can have. I think I just have a questions before we take questions from the floor. I'm not sure if Dr. Kim is online because it's for her. You know, that was an interesting topic on TILs. And I know one of the chemotherapeutic cocktails include, you know, steroids. So how does that affect the accuracy of TILs in measuring event-free survival and overall survival in patients? So immunosuppression, essentially, and TILs.
So that's actually a really great question. Thank you so much for answering that. So when we're looking at screenings for TILs, we tend to do it pre-treatment. And the reason for this is, as you can imagine, in the US, and I can only speak for the US, it is not standard of care to actually do serial biopsies after the patient has received treatment. And so therefore, you know, when we do have cases where they, for whatever reason, have to be given some sort of steroid to mitigate maybe, you know, a symptom that they have from their treatment, it's difficult to kind of, you know, include that as part of the quote unquote setup that we use for the TILS overall product. But with that being said, we're still trying to devise better ways to look at things like, you know, absolutely like the resections and from patients who have stable disease or who are progressing. And then also, you know, taking those as different avenues as well. But that's a really great question. And for the prognostic, you know, portion of it and for the predictive, you know, segment of it, we really do look at pretreatment samples.
Thank you.
I wanted to thank all the speakers for their presentations. Really enjoyed the session. I have one question for Aristoteles and one question for Lisa, Victoria Balancer, Tulane University. I think, Aristoteles, I think you mentioned it, but I may have missed it. Would you comment again, please, on whether, and if so, how the sample size affects the outcomes of your analysis? I'm specifically referring to your example of 10 samples per group, I think head and neck maybe.
Sorry. So actually, regarding the analysis that I presented, it is immunized against these problems. This is the actual problem of the classical statistical approaches. So that when you are performing you know, the classical hypothesis testing, you really need to have lots of samples in order to have good statistical power. But here, this approach is such so as to emphasize on sample-based statistics rather than cohort-based statistics. So it's very, very robust. And actually, what you can see here, you see, let's say, a list of genes, which is encountered separately from each sample, and then through this comparative analysis, you can see that the same genes are somehow, you know, derived from completely different and independent cases, which raises the robustness.
We'll take 2 more questions. We're left with a minute. Yeah. Okay. So we have a follow-up question.
Thank you. I thought that's what you said. I just wanted to make sure that I understood that. Elisa, when you mentioned that you don't find mutations in African American patients in the same genes that are observed in Caucasian patients, you gave a really wonderful explanation as to why that might be, because it might be a different spectrum of variants that they have, and that makes sense. But I was also wondering, in your analysis, all spectrum of mutations are included, or maybe if not, then maybe African American patients have a different spectrum of mutations in the BRCA1 or BRCA2 genes, or the common variants that are common in the Caucasian patients. Thank you.
Thanks. So the variants are defined by the ACMG as far as pathogenic or likely pathogenic, and this is based on published data, data submitted by the companies in silico estimations. And to date, most of that data has been comprised of European cohorts, Caucasian cohorts. So variants of unknown significance may or may not be pathogenic. We don't know because it's underrepresented. Similarly, the panels were assembled based on the data from these cohorts. So these panels may or may not be including regions of interest specific to African Americans. We may not even be looking in the correct genes for African Americans. And so those are problems that need to be addressed. And I think that's the importance of doing these types of studies, is that we're able to identify some of the shortcomings and really shed light on the fact that we have a distinct population which is underrepresented in these data sets.
So I I have one question. So congratulations for all the authors, all the presenters. So very nice talks. I have one question to Elisa. So you wrote, but you didn't address very well the KIT mutations that you found more frequent in African American. This is very interesting because we have imatinib already and PIK3CA already. So are those mutations somatic that you identified hotspots for the drugs that are currently available?
Yes, so we, in interest of time, we didn't talk much about the KIT mutations. Also, we should note that this data wasn't, we looked at KIT in the TCGA data as well as the Tempest data set, and we didn't find that same signal. So the jury's still out as far as we're concerned as to the implications of that. But you are right that the KIT mutations are very important. Looking at the KIT mutations, we actually had kind of a diversity of mutations in the KIT mutations. We had some patients with amplification. We had some patients with missense mutations. So KIT was has a little bit more work that needs to be done on it for us to really understand understand the clinical implications of it. So it was intentional, but the CDK12 is something that we know we've seen in multiple cohorts. We know that there's clinical indications which make it a possibly interesting target as far as African American treatment options.
Just one more question for you, Doc, please. And this one goes to our larger group here at home. You mentioned very interesting findings with working with the ctDNA. What sort of challenges did you encounter and how did you overcome them?
So ctDNA, there are a few challenges associated with it. In good news, in the clinical setting, the ctDNA assays offered by some of the commercial companies have been pretty good and pretty effective as far as for our patients. Now, we have done other studies comparing the results of the commercially available ctDNA assays that we use in clinic compared to in-house sequencing assays that we do. With those assays, we can identify deletions and some other things. And in good news, we found a lot of concordance. We found for the mutations, which are at the highest allele fraction, it was very good concordance. So these assays seem to be very, very good for assessing ctDNA. Additionally, in some of our case reports, and I think Dr. Sartor showed a slide of it yesterday, we've been able to follow mutations and watch them come in and out as patients receive treatment. So it's been a very powerful tool as far as how we've employed it and used it in clinic. And it's also provided a very interesting data set that we've been able to use and look at treatment response with relation to ctDNA. Also looking at subtypes in patients who develop liver mets. In our germline patients, what does their ctDNA look like? So it's provided us an extra window into these patients that's been very effective. As for the actual logistics of ctDNA, it hasn't been very bad. The blood is stable for in the ctDNA collection tubes for a week, so at room temperature. So logistically, it's a reasonable collection. It's not something that has proven to be difficult to implement in the clinical setting. So I hope that helped.
Thank you very much to our speakers for this session. We're just running five minutes behind. Thank you to my co-chair, and we'll hopefully we'll be seeing you in Cape Town next year.
Good morning. Welcome to the last session of this meeting. I'm Tanyani Mrauzi. I'm going to be chairing the session with Prof. Jostna Bartram from Australia. It's all about novel therapies, concentrating mainly on prostate and the colon. Our first speaker in this session is going to be my co-chair, who's going to give us a keynote address. Prof. Batra is laboratory head at the School of Biomedical Science and Advanced Queensland Industry Research Fellow at the Center of Genomics and Personalized Health, that's in Queensland University of Technology. Her PhD was on biotechnology, working mainly on genetic complexity of hereditary disorder. She's leading a research group working on molecular genetics of prostate cancer. Currently, she's mainly focused on identifying cancer risk-associated genetic variants. Prof. Batra, you may proceed.
Prostate cancer, like any other disease, have a huge genetic component. Today I would be talking mostly about molecular genetics. We discussed earlier today about genome-wide association studies, and those who might want to recapture it, it's a very simple, straightforward analysis of comparing germline common variation among populations, disease population versus healthy population. And in this case, I'm talking about prostate cancer. So we have been undertaking genome-wide association studies of prostate cancer in European population for a very long time now. And this analysis has identified several of the common genetic variations which are associated with the risk of prostate cancer, each one of them imparting very, very small effects. So the odds ratios associated with these common germline variants are really small, but then we have started to analyze that polygenic risk score could have values and have been instrumental in several cases, at least in those cases where we do not have enough information about the family history. So when we do the genome-wide association studies, this is all based upon the fact of and using the advantage of the concept of linkage disequilibrium. So we have found some SNPs which are associated with the prostate cancer risk, but we still do not know which one of these are causal variant or has any molecular effect which is going to then relate to cancer pathology. So this then leads to a very big open area of finding the causal variant and the causal gene, which can then be targeted as a therapeutic target. So if we were just talking about the GWAS approach. And thus, they are mostly implicated in regulation of translation. In most cases, halting the translation, but in some cases, they could also be involved in stabilization of the microRNA, of the mRNA sequences. Now, if there is a SNP which is present either in the microRNA gene or is present in the 3' UTR of the mRNA, it can alter the binding of a microRNA to the UTR of that gene, thus interfering with the whole of the process understream of the microRNA binding. Thus, this fine-tuning of the translation, which was being taken care of by a microRNA, will get interrupted because of this SNP. And we call these SNPs as MIR SNPs or MIR SNPs for the ease. So we started to look for the association of these MIR SNPs with the prostate cancer risk, and when we started to look at them, we first looked at in our own population, which unfortunately, at least in my slides here, doesn't come up properly, but eventually we of course realized that our own population size, which was of 3,500 prostate cancer patients and around 1,000 healthy individuals, were not enough. So we need to really analyze these common genetic variation in a larger population. And this is where we became part of the large prostate cancer consortium Practical, who was at that time designing the COGS chip SNPs. And our MIR SNPs, which was in this case 2,000 MIR SNPs, we were able to be part of the COGS SNP chip array. So we then analyzed these MIR SNPs for their association with prostate cancer risk in 22,000 prostate cancer patients and similar number of healthy controls. And this is the Manhattan plot to show you their association with the risk of prostate cancer. So some of the SNPs here were found to be associated with prostate cancer risk, in the previously known regions. Some of them were totally new, and some other SNPs were found and were implicated in novel genes as well. So the beauty of this analysis was that we were already arriving at significant genes rather than arriving in a gene desert regions. So then we also started to look deeper into these genes. And as you can see in this particular slide here, that we also looked at the differential expression of genes, these 16 genes specifically, which we identified through this analysis, which harbor a total of 22 MIR-SNPs associated with the prostate cancer risk. So of the 16 of these genes, 7 were found to be differentially regulated at the expression level when we compare tumor tissue versus the adjacent normal tissue. And kallikrein-3 was our top differentially regulated genes of these genes. Now, very interestingly, when our study came in, or also the previous GWAS studies were published, kallikrein-3, which actually encodes for prostate-specific antigen, which is the biomarker for prostate cancer, we received several kind of revelation and conundrum with respect to a physiological role of PSA in prostate cancer, because PSA is a biomarker for prostate cancer. It is secreted. It is just an overexpressed gene or protein in terms of prostate cancer, but there were implications that PSA might not have any biological or pathological role in prostate cancer. So we have actually summarized its pathological and physiological role in this particular review, and I would ask you, if you have time and you can look at this review, would be of interest to you. But going back to this MIR-SNP analysis, we then started to check how kallikrein-3 gene could be regulated by microRNA due to this MIR-SNP. And to prove this, what we took was reporter gene assays. So for this particular MIR-SNP, there were 3 of the microRNAs which were predicted to bind to the 3' UTR of the PSA gene. Now, very interestingly, not all of them, not all of the prediction was correct, but at least one of the microRNA was able to bind to the PSA gene in an allele-specific manner. So only when there was T allele was present, then the microRNA were able to bind to the PSA gene. Now, this was also proven not just by reporter gene assay, but when we transfected the cells with the microRNAs itself in the cell line, which were endogenously able to express kallikrein-3. The data you are looking here is at the mRNA level, but we also can see that at the protein level, with increasing time point, with overexpression of microRNA, expression of kallikrein-3 goes down. Very interestingly, not just kallikrein-3, but several other members of the kallikrein family, like kallikrein-2, kallikrein-4, and even androgen receptor were found to be down-regulated when we started to overexpress this microRNA 3162 in these cell lines. And we also observed that overexpression of this microRNA leads to reduced prostate cancer cell proliferation. And very interestingly, in the left graph, where you are looking at the microRNA expression in multiple cell lines, prostate cancer cell line PC3, which does not have any endogenous kallikrein-3 expression, seems to have highest expression of this particular microRNA, which is very interesting and also lead to the conclusion that how this particular microRNA can regulate the expression of kallikrein-3. So we were then also interested in taking further analysis, and overexpression of this particular microRNA then reduced to the colony formation in multiple cell lines, which we have tested so far, which seems and points that this particular microRNA not just has a kallikrein-3 as its target gene, but several other target genes. And we were able to shortlist those target genes by the pull-down assays. And as you can see here, kallikrein-2, 3, 4, androgen receptor are the main target genes for this particular microRNA. So we are now taking this microRNA further in animal studies and are proposing this to be one of the therapeutic modalities which can be used as a molecular therapy for prostate cancer. But now going back to the kallikrein locus, which has been very, very interesting locus overall, specifically because of kallikrein-3 encoding PSA. And over the time, we have also done fine mapping analysis of this locus, and with the Practical Consortium have published several papers on this locus, analyzing around now 80,000 prostate cancer patients. And on the detailed analysis of this locus, actually, it was identified that there were at least 2 additional SNPs, common germline again, which were significantly associated with prostate cancer risk and were independent of each other. One of this, very interestingly, is in fact these two which I'm talking about, both of them are non-synonymous SNPs, so a very rare outcome of a GWAS analysis where you will identify a non-synonymous SNP, one of which is actually C to T change, which is also isoleucine to threonine change at the protein level. And so we started to dissect the functional role of this particular variation. Now, the first step we undertook to dissect the functional role of this variation was to overexpress the PSA gene. So we overexpressed it in multiple forms. What you see here is that one is which you read it as WT-PSA, is the wild type PSA. And then we undertook a single mutation into this overexpressing PSA gene, which is represented here as T161 PSA to represent the SNP position at the protein level here. So when we overexpress PSA just in its wild type, prostate cancer cells seems to have highly proliferative properties. So is their migration properties increases by overexpressing the PSA. However, just by doing one amino acid change to the PSA at this non-SNP position, we see the loss of this activity. So next step we started to also look at was its expression on the phenotype. So the previous analysis, which I have shown you, is undertaken in 2D cell culture by live cell imaging, while then we also started to look at 3D analysis and spheroid assays. And to our surprise, we saw opposite effects when we started to analyze the data in 3D aspect. So for example, in this assay, what you see is that cells are highly proliferative in 3D environment when we are overexpressing this mutant form of PSA with SNPs included in it. Similar analysis was also observed when we started to then work with the organoid cultures. So these are the organoids which are again transfected with PSA as well as the mutant PSA. And as you can see here that the mutant PSA shows a highly proliferative and phenotype, and the spheroids are highly proliferative and the bigger in the size as well in the organoids which are overexpressing mutant form of PSA. So this was a little bit surprising for us to observe kind of opposite phenotype in 2D and 3D, and we were not very sure if these were the experimental issues or were related to multiple roles of PSA, which could be possible. This is why we started to undertake the mice analysis. So what you are now looking here is the subcutaneous model where we inoculated PC3 cells overexpressing either the wild type PSA or the mutated PSA into the subcutaneous region of mice, and then look at the tumor proliferation. Now, very interestingly, the tumor proliferation was is comparatively much higher in the wild type overexpressing PSA cell lines inoculated mice in comparison to the mutated PSA inoculated mice. But then again, the biggest surprise came when we started to look at the metastasis. So in this model, which is the same cell line but injected intracardiacally, and we started to look at the metastasis, what we observed that the PSA with the mutated, the cell lines with the mutated PSA are highly metastatic in comparison to the wild type PSA. So this is again an opposite effect what we observe here. So for the local tumor environment, wild type PSA has shown highly aggressive phenotype where local tumor grows significantly bigger for wild type PSA, while for mutant PSA, what we observe that tumor is highly metastatic in these different models which we have studied. So we tried to explain some of these results by undertaking several assays, one of which is also angiogenesis assay. So PSA seems to have inhibitory effect on angiogenesis, which is an important element for prostate cancer metastasis, while as you can see here that the mutant PSA does not seem to have any effect on angiogenesis as such. In fact, it seems to have increasing the angiogenesis effect, if not anything. Next, we also wanted to see what happens in an exogenous model of bone metastasis of prostate cancer. So in this experiment, we grew the bone tumor microenvironment using the stiff material, and then on top of it using the osteoblast cells from human, thus creating a very bone-like environment. And then we seeded our prostate cancer cell line onto this bone-like structures. And here also we see that the cells which have the mutated PSA in them are highly invasive into the bone microenvironment. They show much higher attachment, as well as the shape factor is start to look more like mesenchymal, so they are really invading into the bone microenvironment. Again, supporting our hypothesis that mutated PSA is highly invasive. And this came evident very interestingly at this stage where we started to look at the patient data again. If you remember my previous slide, the odds ratios for the risk association analysis for this particular SNP was less than 1. However, then when we look at the association with prostate cancer survival, patients who have CC genotype have higher mortality of prostate cancer. So even in human samples, we start to observe the opposite effect of this particular SNP, which seems to have low frequency in prostate cancer patients, but then associated with high mortality rate of prostate cancer, which concur very well with our data, which I have shown you previously, that PSA might have an opposite role. And how it might have its role, which is what I'm showing you here, that PSA has got several substrate. The physiological role of PSA is semen liquefaction. So usually this is, while in terms of prostate tumor or other tumors as well, where it's expressed, which are very few, it could have several other substrates like IGF-PP3 or MMPs. And what we see here in our analysis of expressing the PSA, which is produced now in Pichia as a recombinant PSA, that the activity of this mutant PSA against non-substrate, even like seminogenin or MMP2, is highly reduced. Now we really know that a lot of these substrates are very environment specific. So some of these are present in the local tumor environment, while others are involved in tumor metastasis as well. So having this different role of PSA and reduced activity then can impart its functionality to PSA's dual role, depending upon the tumor environment, as well as the mutation which is present in the PSA gene. Now, this was one observation, but another very interesting observation what we could make here was that having this SNP also changes the complexing ability of the PSA. And this is a very interesting experiment we did, was that where we inoculated our recombinant PSA into female serum and sent them into the clinic so that the PSA level can be measured. And to our surprise, the PSA levels comes out to be very, very different than what we have actually incorporated into the serum. And this comes because of the different complexing ability, specifically of the mutated PSA, which is now less active and thus have less complexing ability. So this also brings the concept that if we are measuring free to total PSA levels in the clinic, and the patients who have got these SNPs will give us skewed results. Now then, also using molecular dynamic analysis, we started to look at how the structure of the PSA would be hampered because of this SNP. And as you can see here, that this SNP is not present within the kallikrein loop, or not even within the catalytic triad. However, its position is such that it hampers with the kallikrein loop, which is essentially an important part of substrate recognition. So we hypothesized that because of this SNP change, the substrate binding affinity as well as activity of PSA against a particular substrate changes as a chemical enzyme. Now then, very important aspect, and the last aspect I'm going to show you here, was to really measure the level of PSA at the tissue level, as well as some of the data which you are looking here from the plasma PSA level. And as you can see here, that most of the time C allele individuals who have are associated with lower PSA, also at the RNA level, at the immunohistochemistry level, as well as at the level of PSA secretion into the plasma. Now, if you look at some of these patients which comes into the clinic who seems to have very low PSA but high-grade disease, might fall into this category where it's really difficult to predict at this stage whether the low level of PSA, what we are observing in them, is just because the assay is not sufficient enough to detect this mutated PSA, or this mutated PSA is really now also getting degraded very quickly, which I haven't shown you the data today, but we have some information regarding that as well. And that is what ultimately leading these patients to get detected either later or not receiving enough clinical attention, and then ending up these patients appearing to the clinic with highly aggressive disease. And also at the molecular level, as I have shown you already, that these patients, the patient who have the higher frequency of this SNP seem to have poor survival rate. So this is where I would just like to summarize by putting this data together, that at some stage, if we could develop a new assay which could detect this PSA variant, might lead us to a lot of additional information, and might also in the future help these men to be identified earlier and get detected earlier and receive clinical treatment, which could be of benefit to them. So this is, again, not a work which I would have done alone, and there is a big team of clinicians, technical staff, students, postdocs, everybody involved here. And I would like to thank all of them. And last but not least, the organizers who have given me the opportunity here to share my research today with you. And I'll be happy to take questions.
Thank you. Thank you. Thank you, Professor Batra. Just one question. If anybody has a burning question, there's a hand there.
Thank you very much for that insightful talk. I just want to find out, with regards to angiogenesis, you employed HUVEC, and because tumor-associated endothelial cells behave differently, do you think the observation could be the same using TECs?
So we did, actually not by ourselves, but our collaborators try to do the similar experiment with tumor-associated endothelial cells, and they find also the similar observation, at least with respect to the role of PSA. They haven't tested the role of the SNP in there, but I would expect it also to go in the similar direction. So in this case, we actually took PSA of the tumor cells, so it's the secretory media from tumor cells, and then we inoculated it with the HUVEC cells.
Thank you. Thank you for that excellent presentation. We're going to take a break now, a short tea break. I think we should start. We have another keynote address. This now is from Prof. Mike Sateke. Prof. Sateke is the head of nuclear medicine department at the University of Pretoria here in Pretoria, and Steve Biko Academic Hospital. He also has the South African nuclear medicine research infrastructure. He's well published, and he's a global leader in the treatment of prostate cancer using targeted radiopharmaceuticals. He has had, he's an editor for several major journals, and he holds position in several boards and institutions. Prof. Sateke, please, you may proceed.
Thank you so kindly, Chair, Prof. Mlaudzi. I think one has to congratulate Prof. Dlamini, and thanks for the honor to invite one, and for PACRI to be a success and to be really what will inform how we go around with cancer. And congratulations to the entire organizing team. This is really excellent. And my apologies that we are also having a targeted alpha meeting in Cape Town, hence one cannot be there in person. I think the whole idea is how can we then optimize what we are doing in nuclear medicine, the isotopes that we have. Having had the view of the program, I suppose some of the backgrounds have been given by Prof. Oliver Sarto, who's now actually also here. To optimize this therapy, it's important that we look at what we treat with, the alphas, the betas and then combining them and making sure that really we work as a team, we take everyone with, and we will be successful in that way. But what is the strength then of why should we be speaking in this meeting? I think as you can see clearly from the previous talk of the coach just now as well, and Pakri in particular as well, the strength of what is there, what should we be targeting us in nuclear medicine? We can take from you what we can target, what we can address is the heterogeneity, the microenvironment in vivo in live patients. If we really get the right molecules and the right vectors, we can therefore speak to the SPECT imaging or the PET imaging, addressing the critical factors that can help radiosensitivity, but not only radiosensitivity, chemosensitivities as well. And of clearly, how do we optimize what we do in terms of when we have treated the cancers that they don't repair back, and that, you know, the death is sustainable. And therefore, the issues of working with the beta, the alpha, and futuristically we will work with the OJA. So in other words, we are having from imaging to therapy, radiotheranostics, we see what we treat and we treat what we see using the same molecules, and that's what it is. So what is the landscape? Probably Prof. Mtambula that will speak after will also be touching to this. Yes, often it's the surgery, it's key. Everyone that is ill, it must be clear that it must go out. But I mean, when it comes back and it's metastasized, there are various ways of treating it. And there's really established way proving, of course, but clearly there are newer ways that actually have to go for both hormone sensitive and castrate resistance. And I'm glad that now we're starting to have the nuclear medicine applications going to the fore, unlike being relegated at the end, wherein the patient has got almost limited time to live, whilst we could have perhaps done a little bit of some combinations in the beginning and prolong the patient's life. But I'll come back to it. So why did we choose a prostate-specific membrane antigen-targeted theranostics? We choose this topic because this vector here, it can actually tell us about the prognosis to some extent and whether there is going to be a success in terms of what we're doing, because it is implicated in glutamate and folate metabolism. It is, of course, going to tell us and interact with the damage repairs, and it can work well with the immunotherapies as well. And of course, what we are doing, radionuclide therapy. So indeed, there is a lot of PSMA biology that can actually speak to the core work of Pakri and the colleagues that are there, and we have to explore various pathways that we can actually combine this PSMA molecule from imaging and then go into the therapies, of course. So then if one is saying, so starting with the imaging in itself, I think one would want to appeal and help that really the position paper that will come from South African colleagues, it be looked into carefully, because we think that it's obsolete, that we should be still using, for instance, bone scanning and CT scanning. I know that in many trials, this is what it is included in, but I think with the group that is there and the oncologist, it's about time that we actually have to look into what can help the patient. If you look into this patient, that's really the same patient that if you would have done a bone scan, you would have thought that the disease is limited to only this phase. But if you look, actually, you would have really misguided the patient and therefore mistreated the patient not knowingly. So, I mean, clearly the disease is really massive and it's extensive, as you can see. And therefore, we then alter the management. That is not to say that management gets better in all that. We say we alter the management, but that altering is important. And hence, we really have to then help the patients plan in that way. Then not only that, but when the patients are treated either by us or by chemo or other means, we can also try and speak to response management, as we can see whether there's partial response, stable disease, and progressive disease. You can see before and after it's really expanding, and you really then can change and alter much quicker. And then of course, and similarly, if it's stable disease or if there is good responses, it is there. And clearly then you are also able to predict who's gonna likely live longer in that way. And again, that's from the imaging that we're saying that this is really excellent. Now that we can image well, and we're hoping that this imaging will help to be now in the, hopefully the core of what we do, and not necessarily as a by the way, because remember clearly that if you're gonna not image with this, you really will do chemo, bone scan and CT, but you might actually end up, in fact, irradiating the patient more, but with little benefit. And this PSMA is not necessarily more irradiation than the two combined. And of course, as we treat, this has been done, and there's various studies using lutetium. Lutetium, for the audience, it's really a beta blocker. I think it was covered probably yesterday. It's a beta blocker. It's a type of isotope that you replace the imaging isotope with. As I said, it's theranostic. You see it and treat it. So after you have imaged, you replace the therapeutic isotope with a treatment isotope, which is a beta-1 lutetium. But the PSMA remains the one in the lead, and it guides the lutetium where it must go and destroy the DNA of the cancers. And as you can see, there's good responses, but sometimes we do have patients that don't respond in around a third or so of the patients, depending on the uptake. And what do we do with those patients? Of course, we have seen clearly that you can do the comparison with cabazitaxel, the advancement of chemo, but clearly the side effects are less with a beta emitter labeled with PSMA compared to cabazitaxel. Well, you could say that in terms of the survival, PSMA, it's a bit better in terms of in that way, but I think lutetium PSMA still needs to be optimized as to the dose, whilst cabazitaxel is already optimized and people can give it at a higher dose. But in nuclear medicine, because of various regulations and the reception that is still a little bit with some resistance, we haven't optimized it. So my feeling is that as we optimize the dose of lutetium, clearly the response will even be better than that of the conventional chemotherapies. And colleagues elsewhere have shown that this beta emitter PSMA can also be given in patients that are chemo naive, that they have not had chemotherapy, and then they respond much better, and it's not inferior to those patients that would have had chemo if you compare the two, and that is again to be welcomed. But similarly, if these patients are being treated with lutetium, of course, they don't respond forever. They recur ultimately. And when they recur, we can retreat again. And we can see that the responses are good, irrespective of how many doses they would have had of chemotherapy, even if they started there. So, and that's good news to say, because what we are saying is that how can we also make prostate cancer to be a chronic disease? You know, like, I mean, patients can live with it, but with a good quality of life. And this lutetium, it's doing exactly that. And I think it was spoken to, but similarly, sometimes with a follow-up and how we do it, it's and hence a meeting like PACRI, liquid biopsy could start to play a role as we monitor. And then some of the patients that don't have the receptor for PSMA and how we monitor them, this could come into effect, and I will not delve much into it. But Oliver probably will have spoken about the VISION trial, the most important trial. And then unfortunately, as you can see, that they had to take an oncologist with interest in nuclear medicine to help us through. So then now this is now a registered product, and this is, of course, it comes with the price of being expensive, of course. So, and of course, that being registered, it's now readily available, and it has been shown that compared to the standard of care, it's really doing good. And compared to the standard of care, there is good quality of life. So you can see the control group with the standard of care, really it's reasonable. But compared to this, could say that it's not much, but as I say, the optimization of the dose still has to happen, but nonetheless, it's still much better. And now this is a registered product as we do have it. But as one has said, that's a beta emitter, and that's great. And this is going to be like the core, and that's one that is readily available. But for those patients that don't respond, what about it? So we've got work that has happened, that has started in Germany, to say that if you give this lutetium in some patients, they don't respond at all. As you can see, this patient had nodal disease, but it got worse after lutetium, the beta emitter. Then after giving an alpha emitter, this patient got to respond. An alpha emitter destroys 2 strands of the DNA compared to a beta emitter, which destroys the 1 strand of the DNA. And hence, it's more potent, and it's more the one that probably will have the resistance mechanism being overpowered. This a friend of mine who was here in the department several weeks, actually a radiochemist, Alfred Morgenstern, is the one that shall conceive the labeling of this, and it really it's something that we are working in, and I'll delve into it. Just to compare and recap again, alpha, which is now I'm speaking about, one of those alphas is actinium. It can break the double strand. A beta, such as lutetium, which I spoke about, can break 1 strand, and therefore the DNA repair can occur a bit quicker with this versus this. The dose that we give, the technicalities I'll not speak to, it's around 8 gigabecquerels to start with. When we treat this patient, of course, we select them just like we do with lutetium. They must have the scan that shows there is uptake. The bloods must be within reasonable limits, but somewhat even we can lower the standards of acceptance compared to chemo to get the patients to be accepted. And usually we treat after every second month, and then with a minimum of 2 cycles and a maximum of, usually not necessarily maximum, but usually around 6 cycles, but a minimum of 2 cycles. Whether the patient responds or not, we give them the benefit of the doubt. If they didn't respond, do the scan, and then we can do at least 2 cycles. And some patients have completely responded, but those that didn't respond will not stop at 1 cycle, will stop at 2 cycles. Why then this alpha? As one has said, the alpha, it has got 3 mechanisms of destruction. As you can see here, clearly, it has got an indirect way, the direct way that I spoke about of the double strand, but it has got an abscopal effect, which induces immune response in distant cells, and therefore you can destroy distant cells easily with it. And this is good, and hence the immune combination that I spoke to can also be another enhancing effect, the synergistic effect of the two that maybe if I get a chance, I'll speak to. And then, of course, this is how we get the patients. If they've got less disease, we normally do lutetium, which is less potent and the readily available one, and the registered one. And of course, if it's extensive disease, we do actinium, because that one with this 3 mechanism, it also does not travel a long distance. Therefore, it's likely to spare your bone marrow. So your bone, as it destroys the cancer, it won't destroy the normal bone marrow. Although potent, it won't destroy that easily. So we are as the nuclear community, and in this meeting where I am now, speaking about how to really get the dose correct, because it's difficult for an alpha to really get to the, to optimize the doses and not to give a little or even more. And this work speaks to this, but the technicalities are not necessarily essential here. So the colleagues again in Germany have looked at this in patients that have had lutetium and that have failed under this, and also failed in chemotherapy using actinium. And then you can see that clearly this patient in this plot, they really have responded well despite having various cocktails of therapies, which is something to bear in mind. That patients that are actually, most of the patients in the world will be this type of cohort. But in our situation, sometimes our patients don't have access to chemo, or they don't want chemo. And then of course, those patients, we happen to have more than that, than many places. And really you can see in this, we have demonstrated that these patients, they tend to actually have good response. You can see the even complete remission in some of them, but to have PSA decline of more than 50 in 88%, that is remarkable. The same was found, this patient is living 5 years. And then we have patients that are like 3 or 4 years, but this patient is now, for instance, 6 years. So they tend to even live longer than what the patients would have done if they actually started with various cocktails. So something to bear in mind, that you actually can start straight away with this. Yes, I'll speak to what are the problems with doing that. We just have a paper that has just been accepted as we speak now in terms of actinium and patients that are de novo metastatic but hormone sensitive, that actually do not want to have anything to do with any other things, or they're not going to be touched. Well, it's a fewer patient, 21 patients, but this is an exciting work to say that, they're still hormone sensitive, but they may not necessarily want anything in terms of, we have to remember that, it's interesting to hear what Shingai will say, but some patients then don't want really to be castrated, and we have to respect that. But they can still have alternative therapies. The quality of life is important as well. And you can see that we followed them up, and the majority of them, 31 months, they were still living and not reached their survival as yet. Yes, you will still have some that don't necessarily respond well, but this is an alternative for those patients that are not necessarily needing castration. Just to run fast here to save the time, comparing our work again with different work of the chemo and compared to those that give the chemo, you can see the overall survival is 7.7 if really versus 18 months if there had been various through several meals of therapies. And that is a problem in that way. But if you give lutetium, which is what is going to be inevitable that is going to happen, if you give at least 2 cycles, it doesn't look like you compromise the OS. As you can see, 16 versus 18, it's still acceptable. So we have to really then still work out on, at least if lutetium is not working for 2 cycles of it, don't prolong it, then you're just gonna shorten. If you're gonna use actinium or an alpha emitter a bit later, it won't be so effective. And of course, we have had patients that have had ADT only and then nothing to it. And this is really good work that also shows that the survival is great. And really, again, compared to the other cohorts that have had over the mills, you can see that by 55 months, they haven't reached the overall survival for those patients that have had their PSA less than 50%. I think this is welcome. This is to be welcome to say, well, there is something that can actually help this patient. And this is just to compare 2 of our works to say really indeed there is a prolonged survival. But we can also re-challenge with, just like we do with lutetium, we can retreat this patient. As you can see, we have treated and then they responded and then they relapsed after something like 8 months. And then we have this expression again of PSMA, and then we can treat them again. And that shows again, we can try and make this chronic disease. What about the side effects? Because there's impossibilities that there won't be side effects. You can see that the hematologic effects, we hardly reach a grade 3 and grade 4 of this because of the short range that we are. And this is in patients that are extensively metastasized with bone, and at least not less than 20. So we really, they are rattled in their bone, but still they don't have hematotoxicities, which is good because we know that the elderly patients will have limited reserves of of the bloods, and clearly, at least, we're not compromising this, as you can see, despite the good response. So the biggest problem with our therapy is that we change the patient's taste. The salivary glands really it also goes to the salivary glands, and it does damage it. There's various mechanisms which one won't maybe go into the technicalities thereof that we are trying to resolve, because if we are wanting to justify to start early, but then we shouldn't compromise their quality of life. And this is the biggest drawback that we are having. So we're trying to play with making the molecules big, combining several possibilities, or giving something that will protect the flow to giving to the salivary glands. In our case, we play with giving the dose that is lower as we treat the patient, so that the target organ it's spared. And then, of course, I've just shown you that the toxicities are not bad, except for the taste that we really alter, and the patient have to really be on the salivary gland. Yes, we are saying that people should not be scared. And to finish, Chair, that yes, we still have to resolve, with a global experience, we still have to resolve what will be of the renal toxicity in the long term, what will be of the labeling that will help us spare the salivary glands and to get the correct doses. But we need a multidisciplinary type of clinical trials from neurologists, oncologists, basic scientists, and then, of course, everyone, and including the patient's input as to what they feel like, and really set up that could unlock the production. And of course, one of the solutions is to combine the beta and the alphas very well, and it's happening because then you reduce the dose of the alpha. It looks like it can spare, just to show that really beyond the alphas, there are ample opportunities. If the patient has got beta only, sometimes it might not respond well. If you give alpha, which is what we do, it may respond well, but then the salivary glands are gone. And then, of course, so the combination probably will be an integrated cancer management that we go, because as you can see, the management of 20 and 18 is close to each other as we go. We can also combine with radium. It's another alpha, but just to come to conclusion, as I see beyond the time, to show you that really this actinium works. And it also works in patients that refuses chemo, that refuses hormonal therapy as well, if they don't want to. Yes, I know there is ways of treating this patient, but you cannot force the patients. And really, they respond well, and this is one way of treating these patients, as you can see clearly, like we do. So in this featured article of ours by the highest impact journal of nuclear medicine, we have demonstrated that there is excellent efficacy, there is high potency, and there's opportunities to make this work. Using various combinations. We have to explore various combination therapies. And Chair, colleagues, I'm saying that really we have to reflect. Well, yes, can appear cloudy if you want to see that way, but if we really are going to work well, as one who was taking this picture, is to say we should reflect into how we do our things well, but and come to an MDT trial that will lead us to combinations with chemo, with immunotherapy, and with the things like olaparib and other mechanism of preventing the repairs. Thanks, Chair.
Thank you, Mike. Thank you. We live in an era of load shedding. I think if somebody has any burning question, please, we may ask now, so that if we do lose him, then we have that opportunity.
Mike, great talk as usual, my friend. And I saw you were featured all over ASCO just recently. Well done again. Just a quick question: what's your opinion about small molecules versus antibodies going forward to help with side effect profile and efficacy?
Thanks, Prof. Tamira. So Singi, I mean, the big molecules are there, and there is trials that are ongoing with it. That's really gonna save the salivary glands, but by their nature, then they will circulate longer in the system. Then you might swap one toxicity by the other. So we will then start having the hematotoxicities that will come, and that will be a big problem. I mean, actually, PSMA was there long before, when it was in a bigger antibody and it was not going anywhere. So then you also risk the fact that, especially say you're going to do lutetium, actinium, for instance, then as it stays longer in the circulation, so the molecule might also disjoin. Then you'll have the daughters acid decay going, wreaking havoc and not being internalized into the tumor. Then they can damage the kidneys. So, but I mean, the colleagues that are really keen on this, the J519, they claim, and not they claim, they say that this is a better one. It's not circulating that much. And we've got to give them a chance, because usually the antibodies give us a clue as to how can we make smaller molecules later on. You know, we after starting with the antibodies. Yes, it's something we have to entertain, but maybe a fraction of the antibody.
One last question.
Thank you for your talk. It was fantastic. It's just quite a naive question, but are there other membrane-specific antigens that you can target in the same way instead of PSMA, if that's the problem for the non-specific targeting of the salivary glands? So are there other combinations of antigens and nucleotides that you can use?
Yeah, no, thanks for that question as well. Yes, there are. For instance, we can look at bombesin, which has been there for years, but then the expression, you still miss several patients that are not expressing. Whilst in PSMA, it's around, let's say, to be generous, 10%, but usually it's less than 10% that we didn't express from the beginning. So then we have that molecule bombesin. But we are also looking into things like FAPI, fibroblast activated protein inhibitors, that will look into the environment. So we can combine this with this and then give a little bit less dose of PSMA and then give FAPI, but again, FAPI tends to also go to other places, so it's not that specific. It's not specific in any way to prostate. It goes to several cancers. But we also have a labeling that had been tried to look into using just plain, as you know, radium. We have done a zoledronate that just looks into the bones. Then you start missing out on the soft tissue, liver, and the lymph nodes. So the zoledronate, for instance, as we treat these patients and they do no longer express PSMA, it does respond well. But we can do the same for breast. Again, not specific for prostate. So at the moment, yes, we are struggling, and PSMA is the lead one. The only thing is that perhaps we have to make the molecule of PSMA in the form of a peptide a little bit bigger, like combining it with things like albumin, and then it will go a little bit less, but not like to the size of antibodies like it was asked by Tambira. So you make it bigger, but then which we have tried, but then you also instead of the albumin, the antibodies damages the bloods, but if you make it bigger, then you end up also damaging the kidneys. So the trade-off, it's a bit tricky as to what we are going to do. But at the moment, the other molecules really that I've mentioned they are still inferior to PSMA. PSMA is really, it has revolutionized what we are doing. And I think it will stay like that. We will just optimize the ligand as we go and make it less to go there, but also to start having things like polyglutamate that will prevent the flow, not only necessarily changing the molecule too much, but what else can we learn and experts and like yourselves and PACRI perhaps can also inform us as it is happening in external radiation. Things that stops the circulation would actually work better than us interfering too much with them.
Thank you. Thank you, Mark. Thank you for that excellent presentation. We'll go to the next speaker. It's Professor Shingai Mutambirwa. He's the head of urology at Dr. George Mukhari Hospital and Sefako Makoto Health Science University. He is a peer reviewer for the Journal of Urology, African Journal of Urology, and he's also a board member for the Prostate Cancer Foundation of South Africa, and also involved with the College of Medicine of South Africa. Thank you.
Good morning, everybody, and I'd like to thank the organizers and all of you for coming out today for this really exciting research projects that we've been involved with. And I'm just going to be talking a little bit about what we call Southern African prostate cancer study. One of the things is nomenclature. I know we're waiting for our Minister of Electricity, and he hasn't been named, but we have to be very, very careful about how we name things. And even this study, when we did start it in 2008, we actually did a bit of a misnomer. But what it was based on is the fact that we know that Black Africans particularly, and African Americans, have an increased incidence of prostate cancer, but their mortality, even age for age, is much higher as well, up to 3 times if you're over the age of 65. And compared to Asian patients, it's 5 times more likely that we're going to die if Black Africans. But we've always been comparing when we're doing research, and that's why PACRI, I think, is such an important aspect, is that we're now doing research amongst our own people as well. Similarly, we came to the conclusion, because when we look at Globocon, they were saying that it's about 2.5 times increased mortality with the 2 sub-Saharan African males. But this was based a lot on SEER data and based on African Americans, which have a genetic predisposition. They're mainly West Africans. And if you look at the difference, West Africa actually seems to have a lower mortality from the studies we've been doing compared to South Africa. East Africa has the least, and Central Africa is probably the worst. But all of this leads to the fact that we're going to be having a decreased life expectancy of about 15 years for our patients. And I think the idea that Africa is just one place has not given us enough granular data about what treatments we have to do and what we have to do for our patients. So we began this in 2008 to actually address the local figures about genetics for prostate cancer in Africa. We've got lots of collaborators. We initially started off from MRC. They gave us the initial sponsorship. Cancer also came through with Movember at some stage. And then we eventually decided that this was not going to be just about Southern Africa. It's going to be about the whole of Sub-Saharan Africa. And we changed the name of the study to IDZOMO. Just to bring it back for some of you who do know, this is my mentor and previous head of department, and we talked about it before. He actually was the urologist who taught most of us here, but he also died from prostate cancer, metastatic prostate cancer. And I think he was one of the initiators of this investigations that we did. And I think it's important for us to keep in mind some of the people that have passed and when they're doing these things. So how did we start? We started in 2008. Initially, we were just looking at genetic analysis, initially from Limpopo, which is the northern part of South Africa, for those who are not from here. We then progressed 2 years later to Gauteng, where we are now currently, and we were collecting subjects initially, as I said, mainly for genetic analysis. We were still taking bloods and we're taking demographics from the patients as well, and we only started really incorporating that in about 2012. And this was partly defined by our mentor, our sponsor, what do you call him, the patron, Archbishop Desmond Tutu, who, as you also know, died from prostate cancer. And what we were really trying to do with all of these analyses was to define a population substructure, see what's the differences between the different places that we were looking for, define clinical presentation, and then correlate it with the SEER data, because that's the surveillance epidemiology and end result probably has the best data for most of these trials that we're involved with. And the take-home message really was that we had most of our patients who had prostate cancer had PSAs above 20, and we know that if we're defining prostate cancer as high risk, one of the trifecta is if the PSA is above 20. So 83% of our patients were high risk. When we're looking at SEER data, even in Black Africans, you're only looking at about 5 to 10%, depending on which studies, they're going to be very high risk, and only about another 20% were going to be intermediate risk. What was also interesting is that our controls also, 30% of them had PSAs above 20, but negative biopsies. And this it's translated in our biopsies to the fact that we had a very high rate of high Gleason scores, which is the grading system. Anything above 7 is considered clinically significant. If it's around 6, then we consider it, and it probably doesn't need treatment. But there was a 2-point increase in high risk prostate cancers in our population group. And what was even more interesting in some ways is, again, we're trying to make everything homogeneous, but even just between our Gauteng population, which is a much more mixed population, and our Limpopo population, the Limpopo actually had an increased risk compared almost to above 1.5 times compared to the Gauteng group. So even within our own country, there's huge differences as far as our genetics as well as our outcomes for our patients. With the demographics, we also came up, there was a lot of wide confidence intervals when it came to this, but we did pick up that, for example, the Venda Chilizini had a higher risk of having nasty prostate cancers. But similarly, if they had diabetic, there was also an increased risk of patients getting nasty prostate cancers, erectile dysfunction, and complete balding. And the complete balding is one of the issues that we can address for when we're doing screening as well. So we expanded it. We started to get more patients, and we started looking also at bringing back to the population, because I think even as PACRI, we must remember that it's good to do research, but we must give back and do something different. And we had outreaches to Vembe Providence, where we had interactions with the community, discussed with them about prostate cancer. We introduced ultrasound machines there, which were donated by the Prostate Cancer Foundation and some other companies. We've now initiated treatments for the patients up there as well. So I think it's the byproduct of good research is that we can also help our patients physically. And the initial genetic data that we did actually led to our patron, Bishop Tutu, having the first Black Africans full genome mapped, and it was Bishop Tutu. It was him who gave it to us and published that in Nature, and it was the beginning of the rest of our investigations as well. Just to quickly go through some of the interesting parts, because there's a lot to do with this, but if you look at the tumor mutational burden, you'll notice that in Black Africans, there's a much higher rate in our group than compared to the European and Australian. Similarly, when it comes to TM-Press ERG, almost none of our patients had that mutation, unlike the Western world. And one of the issues when it came to tumor mutational burden led us to realize that this might not be an inheritance, it might actually be something in the environment that's causing this changes, and that's why the tumor mutational burden was so high in the Vembe product. And what we looked at is actually at DDT as one of the chemicals that can actually cause high tumor mutational burden. We know from even with Kay knows that from her unit as well, that there's also a very high risk of DSDs, of disorders of sexual differentiation in the Vembe province. And we need DDT. We're using DDT mainly for malaria control, but the point is there are other aspects that are going to cause a problem, including prostate cancer, including patients with intersex. And we've had interactions now with the Department of Health discussing some of the options that we can do to look. We know malaria kills a lot of people, but there may be other options that we might be able to do which might actually decrease our risk of genetic problems. Similarly, as I said, with the TM-Press ERG, about 50% of Europeans have this mutation. 25% of African Americans, Ghana about 18%, 13% in our cohort. And it looks like in our cohort, at least, the ERG was just made it the patients get it at a younger age, but they weren't as nasty cancers as from the other mutations. Because some of the mutations that we're picking up which are novel to our African population, and the differences are also there between the Vembe province and the Gauteng. We're also now involved with Swatini as well. There are big things that are coming out, but we still can't really pin down anything that we can do actively for these patients. But one thing which I think we can change is that we also were looking at the microbiome of our patients when they were coming through, and it looks like we have a greater abundance of bacterial pathogens in our patients as well, which may be partly protective. And this is in this Eswatini cohort that seem to do better, even though they come present with later disease on androgen deprivation. But I think we're going to need to expand this. We need to get funding, obviously, which we do have, but we have managed to publish some of the data just last year about the microbiome. And with that, I'll just like to thank you for your attention. And if you are willing, if you do want to collaborate with you, Doctor, you can get in touch with me and we can continue, because we've got around the whole of Sub-Saharan Africa. Thank you.
Great, thank you. I think because of time, we'll just take the question at the end. And myself being a vendor, I need to keep my urology friends very close because I'm told usually I'm most likely going to have very aggressive prostate cancer. So I'll keep you very close, my friends, urologists. Thank you. And then we'll then go to the next speaker, Prof. Meyer from the Western Cape. He's professor of biotechnology at the University of the Western Cape and the director of Biolabels Research Unit of the Department of Science and Innovation. He's also well published. He spent 2 years in Ireland for a postdoctoral fellowship, and is also a member and involved in several organizations. Prof. Meyer, good morning. How are you?
Thank you, Chair.
You may proceed.
Thank you. I'm audible?
Yes, we can hear you and we can see the slides.
Yes, thank you very much. Let me start by thanking organizers for inviting me to this meeting. Let me apologize for not being there physically with you this morning. So my talk will be very different from what I've been hearing this morning. So my objective is really to share with you what we're doing here at UWC, and maybe it's also an invitation. So we are doing basic research, but it's an invitation to all the oncologists and those of you working much closer with patients to collaborate with us. So I'm from the University of Western Cape in the Department of Biotechnology, and I'm heading the Department of Science and Innovation, MinTech, Nanotechnology Innovation Center, the biolabels node of it here at UWC. So this center was established in 2007, and that's through the DSI. Back then it was DST, Nanotechnology, National Nanotechnology Strategy, which established two centers for nanotechnology, one at CSIR and one at MinTech. And so we are part of the center at MinTech. And this center consists out of MinTech and then 3 universities, and UWC is part of that. And our focus is very much on research, health research. So the objective is to train people in the field and also to do research or apply nanomaterials in health. And so that is our focus. And specifically to develop nanomaterials for applications in therapeutics and diagnostics. And of course, as I said, develop, train people in this field. So today, I thought it would be appropriate for me to really maybe just focus on what we do in diagnostics, although we do things in therapeutics. So we're doing basic research in this. And our applications, our aims within diagnostics is really, and you will see that our research is mostly focused on infectious diseases, and that's to develop rapid, cost-effective point-of-care diagnostic systems using nanomaterials for diseases such as TB, Ebola, COVID, diabetes, But we also have explored research in cancer. And aside from looking into biomarker discovery, we're also looking at alternative molecules for the detection of biomarker molecules. So we have a specific focus on DNA aptamers. We also work with peptides instead of antibodies. And I'll share later on why we specifically focus on these molecules. So the nanomaterials that we are focusing on specifically is called nanoparticles, so quantum dots. And these have specific uses and applications. So for biologists, quantum dots, because you can make these things, they are fluorescent nanomaterials. We can make them, any color based on size. So we can use them for multiplex imaging. Gold nanoparticles, we can use them in optical sensors. Magnetic nanoparticles and bimetallic nanoparticles have, very interesting properties as well that we can apply in biology. So this gives a kind of overview of our research activities within the diagnostics sphere. As I said, we also do work in therapeutics. But I specifically want to talk about our work around aptamers because I think there is a lot of applications we can do in the diagnosis and even in the treatment of cancer. So these molecules, aptamers, discovered in 1990 by two research groups, independently identified by Larry Gold and Jack Szostak. So in 1990, they both at the same time published work describing the identification of aptamers. So aptamers, and this word first coined by Jack Szostak, is a Greek word meaning to fit. And these are oligonucleotides that have the ability to bind to a target molecule with high specificity. So sometimes they are referred to as nucleic acid antibodies because they behave similarly. And the very first technologies or methods used to identify these molecules is the so-called CELEX. And I'm just giving you a very brief summary of how you would go about finding these molecules. So it started off with a nucleic acid library. And you have your target protein, your biomarker of interest, and it's simply incubation of the library with the target protein, and then capturing those aptamers or oligonucleotides that bind very, very high affinity, and eluting them. You amplify them by PCR again, and then you can repeat this process a number of times until you get to the end, and you then apply DNA sequencing to identify which aptamers bound to your target. So this is what was done in 1990 to identify aptamers. And so these molecules have, as I said, can be used for binding to molecular targets, proteins, very similarly as antibodies do. So over the years, people have developed all manner of different ways of doing CELEX. So this is what people started with, where you have a library interacting with the protein target, but you can also do what's called cell-based CELEX. So taking a cell and incubating that with a library, or you can do a hybrid where you first incubate a cell and then followed by the protein target. And then interesting work that recently people have been doing is where they're doing so-called in vivo CELEX, so injecting your library into an animal. In this case, the example is a tumor. Tumor was induced in the mouse and library is injected, and you then recover the aptamers that bind to the tumor. And that obviously is for applications in diagnostics, could also be therapeutics. So if we compare these molecules to antibodies, this is how they compare. So based on affinity and specificity, they are very much on par with antibodies, high specificity, high affinity. But there are other advantages that we have, and that's the fact that The production cost of these are much smaller because it's a chemical process compared to what we do for antibodies. Because it's a synthetic process, we have little or no batch-to-batch variation, which can be significant in antibodies. To modify them, to attach them to something, is very easy compared to doing it with antibodies. They are thermally stable. If they denature, they can refold, which is not doable at times with antibodies. And then the one that I didn't put here, of course, is the fact that they are much smaller than antibodies. So they are projected to be the new antibodies. And so at UWC, we have initially started doing this work of finding aptamers for targets using SELEX. But we have now moved on to doing this, and that's what most people do, is to develop in silico methods for aptamer identification. And so this is work that was done by a PhD student in our group, where we, instead of doing the SELEX with wet lab based, we do in silico methods. So identify a biomarker, and we have a database, aptamer database that we have assembled, and we do what's called a virtual screen, basically throwing this aptamer database against protein, and this is what you get. There's protein structure and the biomarkers or the aptamers attached to the biomarker. And so that's followed by doing various in silico analyses, molecular dynamics, docking, to identify the best binders. And that's then followed by interaction studies, where we do technology sites as MST to verify the binding of the aptamer to the target, and then its application. And so this is what molecular docking allows us to do. We can visualize the protein and visualize where the aptamer binds. And this is what you don't get when you do SELEX, and that sometimes is why SELEX would fail, because and that, as I said, we have done that in the past. And when you develop a diagnostic assay, fails because you do this almost blindly. So with the in silico methods, we are able to see exactly where possibly aptamer will bind, and that helps us in selection. And so this is what we specifically work on, examples of what we have done. These are the sort of apta sensor diagnostic tests that we develop. So there's the optical sensor, and I'm showing you just two tubes there, different colors, and that could be, well, that is a solution of gold nanoparticles that just simply change color in the presence of a biomarker. We can also develop nucleic acid lateral flow assays, and that's a big focus for us for the infectious diseases, based on the same principle. And then a variation on the ELISA, where you would, instead of using antibody, would now be using an aptamer to detect the biomarker. So these, of course, they have, as I said in the beginning, it's got advantages in terms of cost. That's the most obvious one. And in terms of large-scale production, if you needed to very quickly produce a large number of diagnostic tests for an outbreak like Ebola, for example, producing aptamers can be much faster than antibodies. So there's a number of advantages to this. And then the last one here is using these, and here I have also, I'm putting the type of nanomaterials that we are interested in here and work with. So here at the bottom, I'm showing you vials of quantum dots and how they fluoresce different colors. And for biologists, that's quite exciting that you could use this in imaging. So we are working on technologies together with the aptamers, where we label or conjugate fluorescent nanoparticles like Q dots with aptamers to allow us to use them to detect molecular markers within cells. So these are the technologies that we are working on, and the examples that we are currently busy with. So I'm showing you some applications, and so here we have developed an aptar sensor for the detection of RBBP4, which is a biomarker for diabetes. And I'm just going to quickly run through with you how this bioassay works. And it's based on gold nanoparticles. A solution of gold nanoparticles will have a ruby red color, as indicated here. If you add sodium chloride to that, that will strip the nanoparticles and they will aggregate, and the solution will turn blue. But if you protect the nanoparticles by attaching an aptamer to the surface of the nanoparticles, that will protect the nanoparticles. Solution will stay red. In the presence of the target for that aptamer, so RBBP4, the affinity of the protein is much higher for the aptamer than the aptamer has for the gold nanoparticle. And as a consequence of that, the gold nanoparticles are left free for reduction by the sodium chloride, and it turns and the solution turns blue. So a simple color reaction can tell us whether the biomarker is present. And here, getting an answer within 5 minutes, a detection limit of 90 nanometers and nanomolar. So this is the kind of diagnostic or quick or rapid cost-effective diagnostic devices that one can develop using this technology. We've also developed this for COVID-19. We haven't published this work, but we have reviewed the potential of developing these kinds of diagnostic systems using aptamers and nanomaterials. And you're happy to look at that publication describing that and the potential of these molecules. We have also applied this in cancer. And so one of the things that we've done very early on was biomarker discovery, and one of the proteins that we have looked at for breast cancer, GFRA alpha-1, which is a protein that is overexpressed in breast cancer cells in response, it facilitates metastasis. So it's a membrane protein. So in that study, we were basically looking at membrane proteins that are upregulated in breast cancer cells. And so GFRA alpha-1 was one of those proteins we identified, and others have also pointed to this protein as a possible biomarker. So subsequently to that, we have used CellX to identify aptamers for this protein. And what I'm showing you here is just what is possible and what we have done with this. So here we simply label the aptamer with CY5 fluorescent dye. And technologies or applications that you can then do to show the presence of the biomarker in cells could be microscopy, flow cytometry, spectrophotometry. And here I'm showing you actual results produced by Lauren, showing various cancer cell lines, and basically just quantifying the cells that have stained positive with the CY5 tagged aptamer. And you can see that MCF7, which is a breast cancer cell line, showing very high presence of or staining with this aptamer. We have also developed an ELISA for this. And so, again, as I said before, instead of using the antibody, you would make use of aptamer. And this is the limit of detection that we could achieve with this. So there is quite a number of possibilities with nanomaterials themselves, as the slide indicates. These are the kinds of, and this is more relevant, I guess, to the community doing research in cancer, all of these kinds of diagnostic tests that can be done to show presence of cancer, but combining that also with aptamers, I believe can be very powerful. So we are, I'm going to stop there, and if there's any questions, I'll take questions. But it's really just my objective, as I said, is really just to show the kind of things that's possible. We don't do a lot of research in this field, but we would want to. And let me just at the end then say, acknowledge everyone who's worked. As I said, there's a lot more to talk about, but these are all PIs that's been involved in this center for the past 10-14 years. And then also just to acknowledge our students that has been working on these projects and the institutions that has funded us. Thank you.
Thank you. Thank you, Prof. Mayam. Please stay on. We've gone through our at least load shedding. I will then now hand over to my co-chair to continue with the program. Thank you.
So, may I ask the question online?
You may.
Yes.
Yeah, sorry, Marvin. Excellent talk. Actually, I was very interested in finding out the clinical implications. So, are there aptamers already kind of approved diagnostics or therapy which is already in clinic? You know, aptamer made a very big hype 20 years ago. But do you really think that it has progressed so far, and what have been the inhibitory factors that have not led them to reach to a level where they could have been?
Yes. Yeah, that's a question that comes up quite often, of course. Yeah, there is, of course, the FDA approved drug for the treatment of macular degeneration that's been approved. So it's not cancer. But there is the drug that has been approved by the FDA for the treatment of that condition. There are no examples currently yet for the treatment of cancer, but that's quite a number of aptamers that's in clinical trials for various other diseases. But yes, there has been problems, and there's been many articles written about what those possible reasons can be. For us, one of the problems has been, as we have experienced as well, is the methodology that's been used to identify these, in that finding these aptamers, sometimes people describe it as this black hole, the methodology that has been used, the SELEX. And we believe that doing these things using in silico methodology might resolve some of these problems that we have been experiencing.
So, thank you.
Probably may continue, please.
Yes.
Thank you very much, Marvin. I'm not sure if there is any other questions. Okay, thank you very much, Marvin. So now we invite our next speaker, who is Professor Susanna Sevekovic from Tulane Cancer Center in the USA. And she's going to talk to us about metabolic remodeling in obesity-facilitated colon cancer. Please welcome Susanna.
Thank you, organizers, for invitation and for opportunity to present my work today. I am excited to talk about my fresh data. Some of them are recently published, and some are actually in preparation for publication. So I'm very interested to and excited to show you what we are doing at Tulane University in my lab, and I'm opening invitation for future collaborations on colon cancer issue. So this talk is about obesity and colon cancer. And obesity is an epidemic basically that affects 500 million adults, and it's prevalent in developed and developing countries. So there is no spare when it comes to obesity, like that's one region is more or less. You can see on this graph in the lower left side, what is the status of obesity in 2016 in the world. And unfortunately, this blue is just progressing furthermore. So obesity is associated with multiple disorders, including metabolic disorders, as well as increased risk and progression of cancers, including colon cancer. So this colon cancer is one of the second leading cause of cancer-related death in the, I think in the US, but most likely around the world. So in this map or graph that you can see on the lower right side, it represents actually colon cancer diagnosis in the world. So map actually emphasized that new countries such as China has a very high diagnosis of colon cancer in recent years. So US is now second. But the other countries that are not labeled, did not present data here or graphs, doesn't mean that they don't have a rise in colon cancer. It just means, that collection of data or presentation of data is not there yet. So one of the characteristics of colon cancer is because it was considered before, like many cancer, as a cancer of old individuals. So what we are seeing, actually, despite fantastic diagnostics and surveillance that we have, especially in Western countries, that there is a rise in colon cancer incidence among younger population. If before people in 70s were affected with colon cancer and then people in 50s, now we see more and more people in 30s affected by colon cancer. One of the reasons for that is considered that it's driven by obesity. So the other problem that obesity causes for colon cancer patients is that they're actually more resistant to chemotherapy, and they also have more recurrence of colon cancer after the treatment. It is one of the speculation is that actually obesity transform our stem cells, including stem cells in colon and colon cancer stem cells, and that's actually one of the driver of this problem. So how obesity may drive colon cancer is actually risk and progression is not totally clear to us. One of the characteristics of obesity is that there is systemic accumulation of lipids in lipid storing and lipid non-storing tissue. In intracellular storage of lipids is in organelles known as the lipid droplets. They're actually dynamic fat-storing intracellular organelles that they're comprised of natural lipids, predominantly triglycerides, surrounded with different group of proteins outside of this natural lipids. So main structural protein is known as a perilipin, but there are many other proteins there. So they were actually considered for a long time as just passive organelles in the cell, but in last several years there is a rise in the field of lipid droplets that actually they're very dynamic. They provide a fuel for diverse cellular functions. They also regulate cell cycle, and also they provide the building blocks for new cells. So resting cells that are not lipid storing cells, they actually have a very small, often undetected lipid droplets. But with certain pathologies such as cancer, there is increase in lipid droplets accumulation. Our lab was among the first to show that there is increase in lipid droplets accumulation in colon cancer tissue compared to control. So, and therefore, that may be one of the mechanisms how obesity may facilitate colon cancer progression. What we also did in recent years, we actually identified a very unique reinforced negative regulatory loop between lipid droplets and transcription factor FOXO3. So this mechanism could be actually one of the driving force that balances or bridges metabolic remodeling with transcriptional remodeling. So we have like a main, one of the signature of tumorigenesis is that there is a systemic metabolic remodeling and shift in energy balance. But this mechanism actually also shows that along with this systemic metabolic remodeling, there is systemic transcriptional remodeling that actually backs up in some way metabolic remodeling during tumorigenesis. We also, a few years after our publication. There is publication actually showing that this mechanism exists, is evolutionary preserved, and it exists in C. elegans worms model. So FOXO3 is transcription factor. It's actually involved in many cellular functions, including regulating cell cycle, glucose metabolism up to point that we published our data, and longevity. So how is this important for human disease? Actually, one of our collaborators at Berkeley, he published proteomic analysis, or very systemic, very critical, of lipid droplet protein that we actually use as a platform to create transcriptomic signatures specific for lipid droplets that, and specifically for these proteins that are part of lipid droplets. When we did unsupervised hierarchical clustering using transcriptome of human colon cancer patients that are publicly available. There is more than 450 patients. We asked like a artificial intelligence algorithm, can you find in this massive human colon cancer transcriptomes, a signature for lipid droplets. As you can see in this colorful Christmas tree, what one of my colleagues said, so that there is distinct separation between a normal and tumors, what this lipid droplet signature can do. So it's a highly prevalent signature in human colon cancer. On the right side, we show this data in a more quantified way by using principal component analysis. As you can see, abundance of this signature in human colon cancer transcriptome, that its highly significant p-value is 10 to minus 11. So lipid droplets are highly significant for human disease known as a colon cancer. So as I mentioned, that these are initially considered as a very passive organelles. So recently there is actual indication that that's incorrect. They're very dynamic organelles, that there is a permanent or cycle of their initiation, growth, and utilization. Initiation and growth of lipid droplets is regulated by two specific enzymes that are called, short name, DGATs. They're evolutionary, they're on different chromosomes and they're evolutionary separated, but they still, DGAT1 initiate lipid droplets and endoplasmatic reticulum, and DGAT2 is lipid droplet core protein on the membrane and actually is responsible for growth of lipid droplets, size of lipid droplets. In colon cancer cells, they don't go higher than 5 microns. There is another unique lipase on lipid droplets that it's called ATGL, and that lipase is uniquely specialized to degrade triglycerides and free fatty acids from lipid droplets and deliver fatty acids for different cellular functions. So our interest was to see if lipid droplets are significant or prevalent in colon cancer, what is dynamic between lipid droplets initiation and growth and lipid droplets utilization in colon cancer, because as a highly proliferative condition, cancer, specifically colon cancer, requires or has demand for energy, that metabolic energy for further progression. So we used human colon cancer samples from our local patients, and we found out that there is increased DGAT1, DGAT2, as well as ATGL in colon cancer samples, and especially this increase is augmented by obesity. We also found out that in human colon cancer cell lines, there is increase in these molecules, and it's compared to non-transformed cells, and this increase is further augmented by obesity mediators. So I am conscious of my time, so I am not going in details in with slides, but I'm happy to discuss more. We didn't know how these molecules are regulated. We hypothesized initially that they may be regulated by FOXO3, but we didn't find FOXO3 transcription site. We did a massive cut and run assay, looking for a possibility that MYC transcription factor or oncogene can regulate these genes. Reason why we are looking for MYC, because we published the deficiency in FOXO3 as well as high-fat diet in mouse colon cause activation of MYC. And we were lucky to find that there is actually MYC binding by cut and run assay in both DGAT2 and ATGL promoter region. And then with chip assay, we determine MYC binding sites in both promoters as well. We confirm with luciferase assay that there is induction of MYC by obesity mediator. So what is the relevance of this increase? What if we block these 2 enzymes or 3 enzymes and look like whether they can suppress the growth of colon cancer cells? We used a very specific inhibitors designed for enzymatic activities of DGATs and ATGL, and we found out that actually these inhibitors are very potent, very significantly attenuate proliferation such as BRDU incorporation and colony formation in colon cancer cells. We use different colon cancer cell lines. So because we are very interested to find out what's happening with metabolic remodeling in colon cancer stem cells, because they're one of the drivers of recurrence in colon cancer disease. So we, and because of their heterogenic nature, some of the current treatments in chemotherapy just fail. They just don't work. At that point, oncologists just tell patients, we're sorry, there is nothing else that we can do for you. So, but if metabolic remodeling is unique and like across cancer population, can we use this a common mechanism to target? As you can see, inhibition on this slide, inhibition of DGATs and ATGL lowers this or makes size of colonospheres, which are enriched in colon cancer stem cells, smaller, and also diminishes or attenuates colon cancer stem cells markers in these colonospheres. So we were excited about this, that there is induction or like inhibition of colonospheres. So we also found out that this inhibition actually affects G0, G1 cell cycle and cause actually cell cycle arrest. And there are 2 molecules in cell cycle that are targeted by this inhibition. One is P27-KIP1, and the other one is phosphorylation of retinoblastoma. So we were very happy about this because prior to our work, correlation or like a relationship between lipid droplets and cell cycle was shown only in yeast cells, not in human eukaryotic cells. So I'm not going to go in details how we show this, but there are multiple methods that we did. And please, this very busy slide, just focus on this model in the lower right corner. We actually, just to remind you, in the beginning of presentation, I mentioned that we identified this self-reinforced negative regulatory loop between FOXO3 and lipid droplets. This loop included PI3K. We've showed that before, but now we know that MYC is part of this regulatory loop, and also that this loop communicates with cell cycle. What is as well as DGATs and ATGL, they are part of this regulatory loop. What is exciting for us is if we target DGATs and we actually target ATGL, we shut down this regulatory loop. So there is therapeutic potentials of targeting this metabolic loop. So how is this relevant for disease? I'm just going to go colon cancer disease. I'm just going to go quickly because I'm running out of time. I'm already in negative. So we did systemic transcriptional, systemic assessment of transcriptomic remodeling in colon cancer cells and colon cancer stem cells with these DGATs inhibitors and ATGL inhibitors. And we found out that all critical pathways driving colonic tumorigenesis are affected, such as pathways related to growth, proliferation, and pathways that are related to metabolic reprogramming. This was shown in colon cancer cells, and it's also shown in colon cancer stem cells. We used as a model for this, compared our data to publicly available human data from human colonic tumor crypts. So we're excited about that. At the end, we used mouse model, APC-Min mouse, that it's a model for colon cancer, and we found out that inhibition or providing DGAT inhibitors actually attenuates tumor burden in this mouse model. So I'm not going to go in details. We're excited about this progress, and we just, in conclusion, would like to say that obesity-mediated colonic tumorigenesis via lipid droplets dynamic, which is facilitated by increased DGATs and ATGL, that these DGATs and ATGL actually drive this self-reinforced negative regulatory loop. And if we target these molecules, we can actually shut down this loop and actually attenuate cancer progression. So most of this work is done at Tulane University in beautiful New Orleans by people in my lab. It takes a village to do this type of work. I also have wonderful collaborators at Tulane and in Chicago. My work has been funded by different agencies. And these are just some pics from New Orleans that I would like to invite you. If you come to US, please come and visit us. And I'm open for collaboration, and please contact me when you have time. Thank you.
Wonderful talk. We'll be happy to take some questions now. We don't let you go so soon.
Oh, that's good. I was conscious about time. Yes. Thank you.
Is there any question? Maybe you could help me, because I might be able to miss the question from the audience. So do you see anybody?
No, we have one question from Sheila. We're now on the first name relationship. Yes.
Right. Yeah. Absolutely.
Really fantastic work. Apart from inhibitors of those enzymes, are there other ways you think you could modify the activity of those enzymes through diet or, altering the composition of those LDs, basically?
So these are specific molecules that actually, one of the good things in this field is because it's driven by big pharma that they want to create a pill for people to lose weight. So these are actually inhibitors that are well tolerated. And it looks like they're potent, inhibitors. We used before this a general inhibitor, so fatty acid synthesis, because these lipid metabolism is complex biochemical processes. So we see, this is one of the question about diet. So we induce these lipid droplets enormously by obesity mediators, even more in colon cancer than in non-transformed cells. And they actually look different. Their organization and size is different in colon cancer versus non-transformed colonic cells. So what is interesting, and this is one of the paradox, that if you starve cells, some cells accumulate lipid droplets. There is a beautiful work from Spain. And so the question is, how is this happening? If you feed them with fat or give them fat, cells accumulate lipid droplets. But if you starve them, they also accumulate lipid droplets. So one of the hypotheses that they're working on that is that actually cells have some kind of a communal sacrifice. I'm really happy to mention this. So when they're in the process of starvation, they're all going through this autophagy, and some cells actually degrade more of their molecules, like proteins and other molecules, and accumulate lipid droplets. And they're kind of self-sacrificed. They provide fatty acids and fuel to their neighboring cells. So it's a heterogenic process. We don't know which cell decide to do that self-sacrifice, but when I discovered lipid droplets, increased lipid droplets with FOXO3 deficiency, when I did PubMed search with my collaborator, from Northwestern, when she said there are lipid droplets, I said, what is that? And there were a couple of thousands papers on lipid droplets. And by the time that my first NIH grant was done, there were 10,000 manuscripts. So it's kind of a hot topic in different fields. So more to come on lipid droplets.
Yeah, thank you very much. In fact, I was also wondering on exactly the same lines, whether you think that this would be a colon cancer specific phenomena, because, we associate obesity with several cancers and lipid droplets comes into picture and play role. So what do you think about the specific pathway? Would you like to comment on that?
So absolutely, this is just a cryptic story that, we provided. We have several pathways, that are playing major role in this. So they're actually increased in colon cancer, they're further increased by obesity. So tumorigenesis, we also know there are publications on prostate cancer, on breast cancer. And for example, for prostate cancer and colon cancer, these cells are epithelial cells. They're not equipped to store and they're not surrounded with lipids, with adipocytes, like in breast cancer. There is some specificity for cancer and tumorigenesis that are increased. They're also increased with some infectious diseases. So increased lipid droplets are now considered as some kind of diagnostic marker. And I think, there are some immune cells, like macrophages, are known. If you talk with old professors, in immunology, they used to call macrophages foaming cells because of they have capacity to accumulate lipid droplets. So what was exciting for me when I entered the field of lipid droplets, and that actually there is a whole movement of lipid droplets in developing plants that they can store lots of lipid droplets. They could be used as a biofuel. So, which is remarkable in terms of thinking of new energies. And the other option was it was a gentleman who is working in agricultural industry, developing seeds that are abundant with lipid droplets so that they have a very high, and I was like, oh, please don't make seeds fat. He said, no, it would be very good for cost-effective production in agriculture and preparing food, food production for animals. So there are lots of things that, I hope it would derive from this field. But thank you, everybody, for your questions. And again, my apology for overtime.
Thank you very much, Suzanne. So we next welcome Professor Solomon Rotimi from Convenient University in Nigeria. And he's talking to us again on a very interesting topic on leveraging genomics for improved prostate cancer Nigeria outcome among Black men. So please welcome Professor Solomon Rotimi.
Yeah, thank you very much. Thanks so much, the organizer, Professor Dlamini. Thank you for inviting me for this talk. And I think those who have actually spoken before me since 2 days ago, they have actually laid a wonderful foundation. I've sort of made my work very easy. And so just a little bit of background, just to sort of go over what, has been said before. We all know that prostate cancer risk is highest among Black population or globally. And if you look at the data from the United States, where this evidence for the disparity in the risk and outcome of this disease actually, first of all, emanated, you realize that the regions of the US where you have increased Black ancestry tend to have higher deaths of prostate cancer. One interesting thing, though, is that when you look at, as Melissa said before, that when you look at the composition of African America, you realize that you have a lot of admixture. But what is clear is that there's a lot of genetic pool inflow from West Africa due to transatlantic slave trade. And so the clear evidence that first of all show about this disparity was published by Powell's group that should look at incidental prostate cancer among men who died of other causes apart from cancer, most likely accident. And what they found out is that there's clear disparity, particularly men greater than 40 years of age, in the disease volume. However, when you look at Nigeria population, what we also realize is that yes, men present late, you can argue that, but then after going through treatment within 2 years, a huge proportion of them develop castration-resistant prostate cancer. And part of the argument has been that, maybe it's because they are actually not presenting early, that if they present early, we can catch the disease and therefore the prognosis will be good. And then this is beginning to be answered by looking at the incidental prostate cancer among men in Nigeria that died of other causes. What you realize is that the incidence is actually not as high as that. So the hypothesis, therefore, is that maybe the disease is not being detected late, as it were, but rather when it's detected, the aggression of disease is quite high and it grows so fast. So Of course, there are several factors that contribute to this, but our group is focusing primarily, my research in our group focus on looking at contribution of genetics. And to clearly show the importance of genetics when you normalize for access to care, Cos J published 2 very outstanding papers looking at, the Veterans Affairs Health System, American who served in the U.S. military and have access, retire, and have access to good quality of care. I realized that by the time you normalize, you still realize that Black men still die more from this disease, and that's a very important study. And so several studies continue to show that African ancestry, particularly West Africa, is a very important prognostic factor. But the question, as earlier said from South African studies, that how do you define Africa? Who is an African, for example? And if you're talking of genetics, you realize that Africa is highly heterogeneous. And when we talk about, racial disparity and we're comparing white with black, what we're actually doing in essence is that we're comparing population from these, few groups, very tiny groups, with this huge genetic heterogeneity that we have in Africa. And we're trying to ask the question that can we change the paradigm and begin to look at the way to look at Africa differently. And so there are several things that, variation, that genetic variation, due to adaptation that we have in Africa. And these are some of them. Melissa talked about DAC. We could talk about the contribution of, hemoglobin S, apolipoprotein 1, which is as a result of sleeping sickness. You could talk about changing diet. Are you adapted to milk or dairy-based diet or starch or cassava and tuber-based? I said cassava, tuber-based diet. That's to tell you where I came from. We eat a lot of cassava. Okay. Right. So you have a lot of these, but when you look at the incidence of cancers in Africa, you realize that, for example, prostate cancer ranks number 2. But we've done a scoping review of genetics and genomic study in Africa, where we realized that prostate cancer studies are grossly limited. And running out of time, you look at the GWAS study that have been done. There are 3 of them prior to the study done in South Africa, which looked at the whole genome sequencing. And you look at the risk allele, Tunisia, Ghana, and Uganda. You realize that these are populations that I probably call Africa, but they share different risk allele. So what are the things that we're doing? Well, we've completed whole exome sequencing of prostate tumor from Nigerian male. We looked at about 50 samples. And we compare with TCGA and TCGA African American, European American. Of course, we ran the ancestry to be sure that the people that were working, that were looking at the population we were looking at is actually enriched for Africa. So this is Nigeria, this is TCGA, and TCGA African America, and this is TCGA European America. And we found out is that, and I'm building on that study work done by Professor Oliver and the team from Tulane, where they talked about 12% or thereabout BRCA mutation, and what we are BRCA 1, ATM, BRCA 2, and what we are seeing is that from Nigerian population, we actually have over 50% mutation in this pathway, and that's quite interesting. Because based on the evidence that Professor Oliver talked about, you can clearly see that now we have this population who either will say there was no treatment for them because they've developed castration-resistant metastatic prostate cancer. Because of the enrichment that we have in our population, this mutation, we can now begin to think about how we could deploy treatments like olaparib, into our population. Again, another part of our work is that now that we've seen as a result of DNA repair mutation, we're now beginning to look at the relationship of that with inflammation as a mechanism of driving disparity in prostate cancer, which was first of all established. First of all, indication was given by Professor René Reams, which showed that we can actually use inflammatory pathway differential gene expression to look at this, things that the biology of disparity, racial disparity in prostate cancer. And that was clearly then further validated by the study led by Stefan Arms that actually showed that Black men who use aspirin have reduced aggression when they develop prostate cancer. And so we've completed RNA-seq study, and what we found out is that if you look at the racial gene expression of our population that we have in Nigeria, which is this part, and you compare it with TCGA European America, you could see completely different pattern. Okay, so that's one part of the story. The other part of the story, which we actually zero in on, was that, and again, building on what South Africa study, we are also again part of the DoD-funded Eroica, and the hypothesis that we advanced for that study, for that grant, that proposal at that time, was that we have differential, highly expressed. We pick one of these genes, which is TDO, and what the TDO does is that prostate tumor, upregulates this gene, and this gene, drives tryptophan instead of going to serotonin or protein synthesis, increase the conversion of tryptophan to kynurenine, which we actually have evidence, from plasma level of kynurenine and kynurenine tryptophan ratio, which is, highly, more expressed, the level is higher in prostate cancer cases in Nigeria compared to the control. And then, so what kynurenine does is actually, kynurenine is an immunosuppressor, thereby, making, making the tumor to evade immune system. And so we also went ahead to look at, because we have collaborators across West Africa, to look at a few samples from Ghana and did the RNA-seq study. And we realized that why the Nigerian tumor samples have overexpression of AR, androgen receptor, Ghanaia's samples actually do not have that kind of overexpression. However, when you look at the immunoinflammatory pathway, Ghanaian tumors are sort of highly enriched for immunoinflammation. And so just in the next 1 minute or so that I have, this is the the team that we're working with for the IKEA project, which is what we coined for our DoD-funded Eroica. And what we do is that we're actually discussing and interfacing very closely and working very well with prostate cancer survivors. In fact, we sat down with them before we developed this idea. One of the things that they talk about was that no matter the science that you do, all your high-falutin genomics, what we're just interested in is how can our quality of life improve? And as such, one of the studies that I'm leading in Africa, West Africa precisely, under this project, we're looking at assessment of the contribution of biological factors derived from cancer to poor mental health, because we understand that apart from urological problem, these patients actually, these survivors actually complain about, things around neurological symptoms cluster. And we're recruiting patients from across Nigeria. As you know, Nigeria is quite big and diverse country. We have samples that we've recruited, patients that participants that we have recruited from Niger, Benin Republic, Ivory Coast, Liberia, Cameroon, and now Cameroon, of course, yes, Cameroon, and then Sierra Leone, and now we got additional funding from NCI to expand that to Kenya. Again, just before I close, one of the things I also do is I chair the Aortic Research Committee, and we have this conference coming up in May 8 to 10. Please, I encourage you to also find time and be part of it. What we're trying to do is to sort of create awareness about cancer genomics in Africa, and you could see there's deficiency of research in that area. We're thinking we should create awareness about that. Thank you very much.
Thank you, Prof. Bertram. Can you still hear me?
Yeah.
Okay, great. Thank you. Thank you. Excellent
Thank you
session.
very much.
Thank you. Excellent session
Absolutely.
to close or to end the meeting. I see there are no questions. Or just, please, we'll allow just one question because of time.
Thank you, Professor. It's a question and at the same time a request or an answer to this problem. It's for you and Professor Mutambiro. The prostate cancer is somewhat unusual when compared with other types of cancers. This is because many prostate tumors do not spread quickly to other parts of the body. Some prostate cancers grow very slowly and may not cause symptoms or problems for years or ever. Now, the question I'm asking the House and those who are involved is, have we generated the screening tool which we can use, for instance, to later apply for prophylactic prostatectomy like in other cancers like breast cancer and ovarian cancer? Because it looks like the answer might be lying there. Thank you.
Yeah, absolutely. And I don't know if Professor Mutambiro also wants to comment to that. Yes, you're very right. And what we're doing actually is to bring the solution from home, to say, let us sit down in Africa and let us look at our problem. Yes, I agree with you. We need to develop that too. So one of the things that people are looking at is to look at, and can we use less, non-invasive approach like urine, to see if we could use that to screen. So these are very much, in my own opinion, still in early stages, and none of such has been tried in Africa. Okay, so, but again, another question is that just like PSA itself, you look at the clinical trials that were used to approve PSA, there was none of them done in Africa. And then you could hear the kind of high PSA level that you have in South Africa. And I can tell you, it's the same that we have in Nigeria. You see men presenting with PSA level in thousands, 1,000, 2,000. And so we really need to, and Kate touched on that yesterday, right? So we really need to look at what is our own baseline PSA. What should we be using as our reference? Again, we also need to take leverage on this, upcoming innovative genomic approach to develop, technologies, tools that we can use for our population and we can validate within our population in Africa.
Thank you very much. I really appreciate, but in the interest of time, we should carry on this discussion after the session. And with this, probably we shall close this session and welcome our next keynote speaker. So I hand over to my co-chair.
Great, thank you. It was an excellent session. As I've just said, for me as a surgeon, the talk that I understood very well was the one by Prof. Mayer when he talked about nanoparticles and quantum. Because when I go to the shop to buy TV, I'm told the nano TVs and the quantum, they are the best. Anyway, having said that, I'm also given another task of handing over gifts to our international speakers in this session who are physically present here. I'll just start from the top in terms of the order that we had in our list. Please, if I may have Prof. Chatsiono. No. Wait. Is it out of? Okay, we'll come back. Please, Prof. Zagovic, where's she? She's also gone out. Oh, everybody's tired. And then we can please, Dr. Lidet. Please, thank you. And then please, our last speaker, I'm sure he's still in the room. Yes. Prof, you may just come down, please. Thank you. Thank you very much. Thank you. Yours. Thank you. The other, I will we'll hand them over later. The last talk that we are going to have, please, is going to be our keynote address, closing address. It's going to be from Prof. Leslie Zulkem, who's from the Cape. She's the Vice President of the South African Medical Research Council, Extramural Research and Internal Portfolio. She's a pediatric cardiologist in the Red Cross War Memorial Hospital. Please, Prof, you may proceed.
Excellent. Thank you so much. So I must first say that I understand that I'm holding you between your lunch and your social fantastic conference so far. I've not been able to be there at all of it, but the talks that I was able to listen to today were really inspiring and really comprehensive. So I'm just going to close this meeting with just a few short remarks about the role of the SAMRC in fostering funding and empowering cancer research in South Africa, And for the international attendees, some of this may be new. And for our South African attendees, hopefully we can work together to do what you suggested in this particular meeting, so that we advance prevention and transform care. So the SAMRC is really very proud that an SAMRC unit, precision prevention and novel drug treatments for HIV-associated cancers, was launched under the very strong leadership of Professor Zodwa Dlamini, who I'm sure is in the room. And this has given us a new focus in terms of our cancer work, as well as the mandate to empower and to advance life for all those living in our country. So, and from here has stemmed, of course, PACRI, and I really use this opportunity, all protocol observed, to thank Professor Dlamini and to congratulate her on her wonderful work, her amazing team, and then all of you gathered in the audience today. Again, also my apologies for not being able to join you in person. So PACRI is about defeating cancer together, and that speaks very much to the SAMRC mandate, where we take on some of the major health challenges, but we try and do that in a collaborative fashion. So just to let you know, the South African Medical Research Council is legislated. It is parastatal, and the objects are that through research, development, and technology transfer, we'll promote the improvement of the health and quality of life of the population of our republic, and to perform such functions as may be assigned to the MRC or under this Act. So a very good example of that was the last 2 years, where much of the work of the SAMRC pivoted towards the COVID response. We were involved in multiple of the ministerial advisory committees, and those of you who understand the South African landscape will know of the massive success of the Sisonke trial. What are the goals of the South African Medical Research Council? It's to administer health research effectively and efficiently, and this is of critical importance in our country at this particular time. We lead the generation of new knowledge and facilitating translation into policy and practice, and that is really an extremely important element of the creation of new and relevant knowledge. Support innovation and technology development to improve health. And just in the snippet I heard this morning, there are many other avenues that I think we can explore if I've heard what you're all involved in. And then, of course, what is very important for all of us together is to build capacity for the long-term sustainability of the country's health research. And then to take all of that knowledge and capacity into policy and practice. So if you look at our research priorities and our different areas of focus, as my co-chair so kindly introduced me, I'm a pediatric cardiologist now working at the Medical Research Council. So of course, maternal, newborn and child health is very critically important to me. We understand the HIV, AIDS and TB pandemic that we are still living in. Violence and injury is a new an emerging threat to our country and our country's medical outcomes. But then, of course, we've got non-communicable diseases. Apologies. And as a cardiologist, this is critically important to me, and as oncologists and those working in an oncology field, I'm sure it is to yourselves as well. And so this is for us an important research priority, and therefore it has always been a focus for the MRC. But what I've decided to do is just tell you a little bit about what's happened in terms of the challenges and how we've addressed them. So pre-2012, the funding for cancer was in different pots. There was the intramural units, there were two of them. There were two extramural units and CARISA, which was an initiative related to cancer research. And so those were in 5 different areas. But these research initiatives operated separately. They were not linked to patient care. And there was a very strong feeling that we needed to improve scientific contributions in cancer. CORISA was the Cancer Research Initiative of South Africa, which was a partnership between the MRC and the NGO Cancer, which was quite unique in a way that you had that kind of partnership between those with lived experience and the SAMRC. But the feelings were that outputs had got to a point where they were of importance, of impact, but perhaps not as far-reaching as we would have hoped. So post-2012, there was a formal consultation with cancer researchers. This was happening at the same time as the SAMRC was revitalized and rechanged. And there was a cancer research consultation meeting and developing a cancer research strategy. And I think what is critically important here is the issue that this was a consultation and a issue where together we looked at the research priorities around cancer and cancer funding. And so this resulted in a fourfold increase in research funding with RFAs together with the National Cancer Institute and the NIH, funding of clinical cancer research centers at medical schools in the clinical space, and then establishment also of SHIP, which is our strategic health and innovative partnerships which promote innovation and product development. So this is a partnership with the Department of Science and Technology, or now Science and Innovation, and the Bill and Melinda Gates Foundation. So we're dealing here with many issues. So on the right, you all know these slides, I'm sure. On the right is what we're looking at in terms of incidence rate per 100,000 in South Africa for the various cancer types. And on the left, the issue of costs of cancer, which I'm not sure if you've dealt with in your wonderful conference, but is something that we're also very interested in, is the health economics of how we deal with specific research and health priorities. So what are the current funding mechanisms for cancer research? At the MRC, we have intramural research entities. We have 11 intramural research programs, and none of them are exclusively for cancer. We have a non-communicable diseases research unit, but these intersect across all the different silos. So for example, there is an intramural unit on health policy and prevention, and they look at policy documents, for example, related to TB or to alcohol, which then lead to our risk factors for cancer. Then we have our extramural unit, and we'll go through those a little bit later. We've got clinical cancer research centers. There is the SAMRC NIH program of collaborative research. We fund self-initiated research grants as well as the SHIP grants. So the intramural research entities, two of the most important in this particular regard is the Burden of Disease Research Unit, which has an Eastern Cape Cancer Register, one of the oldest projects in the MRC. And this is one of the predominant rural population-based cancer registries, and is thought to be the only probably fully functional and comprehensive population-based cancer registry in South Africa. We do feel that there's areas in which this can develop and improve, but to date it has played a critical role in providing information about the patterns and the trends of cancers, as well as the direction of intervention programs in the Eastern Cape province. We've got then ERICA SA, which is Evolving Risk Factors for Cancers in African Populations. Many of you may know about it. That is funded by the MRC and the UK government's Newton Fund, and looks at lifestyle data, biological samples from the Johannesburg Cancer Study, over 20,000 patients, and also looks to investigate the causes and enhance scientific research capacity around cancer. And then we've got the genomic platform, which is very important, was established in 2019, brings affordable whole genome sequencing to Africa. This is really to facilitate health and are really working in terms of precision medicine for cancers. Then you've got our extramural units, and of course our flagship, led by Professor Zodwa Dlamini around precision oncology. This one seeks to mapped the landscape of cervical and esophageal cancer, and importantly discovered targets for development of novel and more effective targeted therapeutics. We've got an antiviral gene therapy unit. This is based at WITS and researches gene structure and DNA approaches to treat disease. And then at UCT, we have the precision and genomic medicine unit led by Prof. Raj Ramazar, and has been particularly important in identifying patients at risk for colon cancer and blindness to the point of reversing the outcomes. Stem cell research therapy stem cell research and therapy unit based at UP, looking at non-communicable and communicable diseases to decrease those. And then 2 new units that were funded in the last 2 years for pharmacogenomics research and translation, and the intersection between non-communicable diseases and infectious diseases, led by Professors Colette Ndara and Professor Ntubeko here at University of Town. And those speak very much again about targeted, individualized pharmacogenomics and the intersection between AIDS and infectious disease, in particular around issues such as cancer. So then we all have the clinical cancer centers, and this was really important because it spoke to the need around clinical cancer centers. So it integrates cancer-related research programs in various fields, but to do that in a transdisciplinary manner, but still making sure that they embedded in a clinical unit. So there are 2 of them. The one is led by Professor Linde. This is at the University of Cape Town's Gynecological Center, with a particular focus here on cervical cancer. There's very strong collaborators at Walter Sisulu University and in the Eastern Cape, and their key objectives was to establish a register to speak specifically and deal specifically with cervical cancer prevention, and monitor and understand what is happening with HPV vaccination programs across our country. The WITS Common Epithelial Clinical Cancer Research Center, led by Professor Paul Ruff, also linked to Johannesburg Academic Hospitals, Chris Harney and Charlotte Maxeke, is looking at focus areas: breast, colorectal, hepatobiliary, and pancreatic cancers. And then we have the SAMRC NIH Program of Collaborative Research. This was an MOU that started in 2013 to establish a program of collaborative biomedical research. In phase 1, which was up to 2020, there were 4 major grants. This was related to HIV-related malignancies. And in phase 2, 2 grants that went to WITS and UCT, both around breast cancer screening and cervical cancer screening. So I always remind people that the South African Medical Research Council has either funded or funding or will fund in the future virtually all clinician scientists that work in the country, including myself. This all starts with a self-initiated research grant, which is a small grant, but it supports original research in various entries at a small quantum, but actually provides that step up for young researchers, especially our early career researchers, to take up their first research grant, and then our mid-level and established researchers to take up their next grant, which moves them up the ladder. And so the idea is that this is really around a clear focus for capacity building. I'm not going to go through these in detail, but it's really to show you that there are several of these with a specific cancer portfolio. And then our strategic help and innovation platform, we mentioned that earlier. This is through the Department of Science and Innovation. Major Stellenbosch is the development of a rapid DNA test for improvement in detection of patients with breast cancer, and at Stellenbosch University, a pharmacogenomics platform, again using point-of-care screening and whole genome sequencing in cancer treatment. So what's slightly different about these projects is that it really speaks to innovation. So trying to look at potential therapeutics, potential signature tests, potential point-of-care screening, and how we can move that from a research project into implementation. So I'm going to wrap up now and let you get on with the rest of your day. But I just want to conclude by saying that we value and recognize the real importance of cancer as a research focus, especially as we see the emergence now of non-communicable diseases, some of them based on the infectious diseases of the past that's still present but not to some degree diminishing in their incidence. And we really need to focus on these. And so we have focused in the last 5 or 6 years or so on cancer registry and surveillance, prevention, diagnosis and treatment. Very important is the issue of public health and public health system strengthening. And here I also add in cost effectiveness and health economics, and how those actually intersect with the research world in terms of basic science or clinical research. Research capacity development is crucial so that we build new thought leaders and research leaders in this area, and moving into the next era of genomics, precision medicine, and research translation. We are now coming to the end of the 2 cancer clinical research centers. We're going to have a scientific review to plan our way forward. And again, the idea will be to do this in a collaborative and joint fashion. So a cancer research think tank, to which many of you will be invited, is planned for this end of this year or early next year. And we hope we can move things forward quite rapidly in that particular way. So with this, I thank you for your attention. Thank you for having me. Again, let's focus on the tagline of PACRI, which is defeating cancer together. And I wish all of the delegates a very fruitful end to your meeting. And for those of you who are visiting South Africa for the first or repeat time, again, a warm welcome. Enjoy your time left in the country, and thank you very much indeed.
Thank you. Thank you for the excellent meeting. The meeting has been closed. All thanks to PACRI led by Prof. Dlamini. I think we can safely go and have lunch. Thank you. And everybody, please travel well.